So welcome to our 5th annual What's Best for Breast. I'm going to be your host for today. My name is Jennifer Plichta. I'm the director of the Breast Risk Assessment Clinic here at Duke, where I'm also a breast surgeon. And then I also happen to be one of the founders or co-founders and the current event chair for What's Best for Breast. So thank you again for joining us today. We're so excited that you could be here. Today, we've got a lot of things to cover, but want to start out with a few thank yous, starting with our event sponsor for the 5th year in a row, and that would be Invitae Genetics. So thank you for their generous contributions so that we can continue this event year after year. I also want to thank our planning committee, including Jackie White, Connie Kim, Megan Rooney, Tina Picciarelli, Sean Streeter, Kathy Trotter, Valerie Worthy, and the Duke Cancer Institute's Office of Health Equity. In case people are not aware, Breast Cancer Awareness Month is October. So of course, this is when the American Cancer Society has their Making Strides event. And we hope that some of you will be able to join us on October 23rd. And you can visit their website, ACS Making Strides, to help sign up for the event. Or if you don't feel like walking, you could even sponsor our team. So we hope that some of you will be able to join us. There will be a survey at the end of today's presentation, and we do value your feedback. So please do click on that survey. It just takes a minute or two to fill out, but we would really appreciate any suggestions you have so that we can continue to make this the best breast event in the local area. For those of you interested in other upcoming events, we do have a website, breasthealth.duke.edu. Feel free to check out the website. There will also be a link to today's recording. For those of you that need to leave early or want to revisit some of this information, you can visit our website where you can find the recording and other information about what else is going on in breast health. Today, we're going to start off with our first education session, which will last about 50 minutes or so. Then we'll take a short break for those of us that need to use the restroom or grab a snack. And then we'll come back for our second education session, followed by another 5 to 10 minute break. And then we'll have our final education session with speakers. And then we'll have, actually after today's event, starting directly after and in this same session, we'll have a more information panel where we have some guests from around the community that also specialize in breast health that had some additional information they wanted to share. It'll be much more informal and really just a chance for you to ask additional questions in case you didn't get them all answered earlier in the day. So again, the more information panel will begin promptly at the end of today's session, which is the formal session is from 9 to noon. But please stick around if you have other questions you'd like to have answered. So the first session today will feature a survivor, a breast cancer survivor. She's actually also a physician that used to work here at Duke, Dr. Jennifer Eaton. We're then going to do our Mythbuster session with Megan Rooney, and then we'll do primary care for women's health with Liz Boltaro, and then breast cancer risk and genetics with Jackie White. So now I'd like to introduce our first moderator, Dr. Kathy Trotter, who is also a nurse practitioner within the Department of Surgery and specifically with our breast surgery group. She's a women's health clinician who specializes in breast issues, breast cancer risk assessment, and survivorship care. She has national experience in shared medical appointments and offers group education sessions on breast health issues at the Duke Cancer Institute. When not in clinic, she enjoys teaching nurse practitioner students at Duke. And at home, she enjoys all sorts of outdoor fun, such as bicycling tours, gardening, and time with family and friends. So with that, I'm going to turn the screen over to Dr. Trotter.
Good morning, everybody. Quick question, Dr. Plichta, would you like my video on or leave it off while the speakers are on? Just want to clarify.
Yeah, if you don't mind, if you're not speaking to all the panelists, if you can have yourself muted and your video off, that way the only video that'll show will be the speaker. Thank you.
Okay, great. Well, our first speaker has actually created a wonderful video. And so I'm going to encourage everyone to turn up your speaker so that you can hear it. It is Dr. Jennifer Eaton, who is a survivor. And she was, as Dr. Plichta mentioned, she was previously here at Duke, but is now an associate professor of obstetrics and gynecology and current director of the Division of Reproductive Endocrinology and Infertility at Brown University. So we look forward to listening to her video, and she will be there at the end for question and answer. Thank you.
Good morning. My name is Jennifer Eaton. I am a breast cancer survivor, and I'm here to tell my story. So it was May of 2020 during the pandemic when I randomly happened to feel a small lump in my right breast. At that time, I wasn't routinely doing self-examination. It was purely by accident that I felt it. And I'm actually a physician. I'm an OB/GYN. I'm a fertility specialist. And so I've got quite a lot of experience in breast examination. And over the course of the next few days, I just felt that there was something not quite right about this lump. So I felt at that time, I felt a little bit embarrassed to reach out to my own OB/GYN because I felt that most likely this bump was going to be nothing. But I did reach out. I sent her a message and she was able to get me in for my mammogram at Duke within 2 days. Interestingly, I was 43 at the time, and I had started routine mammograms at age 40. I had never had an abnormal mammogram. I'd only been told that I had dense breast tissue. So I went for my mammogram, and there was a small area that they thought was concerning, but then they double checked it and said that it was benign calcification. But because I could feel a lump, I then went for ultrasound. And on ultrasound, they found the mass and thought that it had concerning features. It actually wasn't the same thing that they had even been seeing on mammogram. This mass hadn't been seen at all on mammogram. So I immediately had an ultrasound guided biopsy. As a physician, I know how physicians talk to patients when they're worried, and I knew that the radiologist was worried. She told me that she thought there was a reasonable chance that it could be cancer, but that it was small, so that it would be treatable if it was cancer. So that was a Friday. I spent the entire weekend terrified. I returned to work the following week, and on my birthday, which was May 11th, I checked my own results in the computer because I worked at Duke at that time, and I saw the diagnosis, which was invasive ductal adenocarcinoma, grade 2. At that time, I reached immediately back out to my OB/GYN, who was also my friend, and she had also just seen the result. We talked it over. She was able to get me in with a breast surgeon, Dr. Laura Rosenberger, the following day. I went to see Dr. Rosenberger. I thought she was fantastic. She gave me great information. She also did an exam and felt another lump on my other breast, on my left breast, but assured me that it was most likely benign. I felt it myself. I felt also like it was probably benign. And over the course of the next few days, she did schedule me for an MRI to follow up the breast lump. I also met with my oncologist, Dr. Kelly Westbrook, also at Duke, and also just absolutely amazing. She also felt the breast lump, but I had already scheduled my MRI at that point, so I wasn't particularly concerned. I went for breast MRI and again, looked at my own results on the computer and saw that there was concern that it was cancer. And the following day, got a call from the radiologist saying that they were very concerned that there was cancer on the left side as well. And in addition, there was possible cancer extending from the lump all the way out to the nipple. That was the first time during all of this that I cried, actually. I really was beside myself. I didn't know what to do, and I didn't know how this could possibly be happening to me because I had always done all the right things during my life. I did everything that I was told to do. I was healthy, I exercised, I had a normal BMI, I didn't smoke, I breastfed both my children. So I didn't have really a family history either. My grandmother had breast cancer, but when she was elderly. So I just didn't understand how this could be happening to me, also with my mammograms always being normal. So I went to my husband, cried, told him that I thought that I had breast cancer in both breasts, and went in and again had an ultrasound on the left side. The radiologist told me that it was almost certainly cancer, and she biopsied it that same day. I also was scheduled for an MRI guided biopsy of the concerning area that was extending out to the nipple. I received both those biopsy results. The lump on the left, again, came back invasive ductal adenocarcinoma grade 2. The other area extending out to the nipple came back lobular carcinoma in situ. At that time, I had already, in essence, made the decision that I was going to want a double mastectomy. So I finalized that decision with Dr. Rosenberger. We discussed whether or not nipples could be conserved, and I felt strongly that I wanted them to be removed if there was any chance that they were going to increase my risk for recurrence. So we decided on a non-nipple sparing double mastectomy. I also met with Brett Phillips in plastic surgery at Duke, who is another person who I'm so grateful too. So we discussed my reconstruction. Because of my body type, I wasn't a good candidate for most of the autologous tissue grafting options. So instead, I opted for placement of tissue expanders with the ultimate goal of having implants placed. So I had my double mastectomy. Final pathology came back with the bilateral invasive ductal carcinoma. Thankfully, it was positive for hormone receptors and negative for HER2. So those two tumors were a very good prognosis. Unfortunately, they also found a third and different type of cancer in the lobular carcinoma in situ. They actually found an invasive lobular carcinoma, which also was positive for hormone receptors, but was HER2 positive as well. And Dr. Westbrook called me quite late at night to tell me that my cancer was positive for HER2 and that I was going to be requiring chemotherapy. She knew that this was going to be really difficult for me, not just because it's, of course, difficult for everybody, but because in the midst of all of this, I had accepted a new job as a division director of fertility at Brown University in Rhode Island, which is where I am currently. And I was in the process of selling my home and moving from North Carolina to Rhode Island for this new job as a division director. So we discussed chemotherapy. I had a port placed. I moved to Rhode Island and immediately started my chemotherapy regimen here. With my first round of chemotherapy, unfortunately, I experienced an infection of one of my tissue expanders and ultimately was admitted to the hospital. We tried to salvage it with antibiotics. I did home antibiotics and none of it unfortunately worked. I think I was just too immunosuppressed from the chemo. So I had emergency surgery here to remove the infected tissue expander. At that point, I was told by 3 different surgeons that I would never be a candidate for having a tissue expander placed again because of the prior infection. But I found one surgeon in Boston, Dr. Bernard Lee, who was willing to try. We discussed the fact that there was greater than a 50% chance that it wasn't going to work and that it would just need to be removed again. But for me, I was willing to accept that chance because my other options were going to be really difficult surgeries with very long recovery times. And I thought also they wouldn't have an optimal aesthetic outcome. So ultimately, I had a 3rd surgery with placement of another tissue expander, and it actually worked. And just about not quite 2 months ago, I had the expander exchanged for an implant. I have finished a full year of infusions. I did 4 cycles of TC chemotherapy along with Herceptin, and I finished off a full year of Herceptin infusions as well. I've had my port removed. I'm feeling great. I think I'm done with surgery now after my 4 surgeries. And I am just in the process of trying to reclaim my life because as all the survivors out there know, cancer tries to steal a lot of things from you. And it's up to us to get those things back. So one thing that was really important to me during this whole process was to stay healthy. So I was always somebody who exercised prior to treatment. Dr. Westbrook encouraged me to exercise during chemotherapy, and that was one of the best pieces of advice that I ever got. I exercised throughout chemo. It wasn't always as much exercise as I wanted to be able to do, but I did what I could. And I really believe that it helped me avoid most of the negative side effects of chemo and helped me feel normal. I also cold capped. So I did lose hair. I lost actually quite a bit of hair, probably half my hair, but I never lost all of my hair, which was important to me because I have 2 children. And my daughter, who at the time was 8 years old, had expressed to me that the scariest part of all of this was the thought that I might be bald. And so the fact that she never had to experience that was life-changing for me. And then the other thing that was really important to me was because I have children, I met with a child life expert also at Duke who gave me great advice for how to talk to my kids about my cancer in a way that they could understand and in a way that would be honest and not scare them. And so I'm very grateful to her as well. So that's my story. Everybody's story is unique and different. I am really grateful to be able to share my story today. And to all the survivors out there and those who are currently undergoing treatment or those who have just received your diagnosis. I see you and I'm thinking of you and I wish you the best. Thank you.
Excellent. Thanks for sharing. And she will join us at the end when we do a little bit of Q&A. Our next speaker is a rising star at Duke Medical School, Megan Rooney. And we are so happy to have her lead us in Mythbusters. So turn your brain on and see what you think about this.
Hi, everyone. Let me just share my screen.
And while she's doing that, Dr. Plitka, I had good volume, so I could hear her well. So I think it was great that we were able to hear her. Okay, Megan, go ahead.
Okay. Great. So yes, as my name's Megan Rooney, and I am a third-year medical student. So we are going to do some polls. So the first one is most lumps in your breast are not breast cancer. So let me launch the poll. So everyone can.
Okay, Megan, you can usually give about 20 seconds and they should be
Okay.
logging on.
Great. So good job, everyone. Almost everyone got this one correct. So this is indeed true. So only a small percentage of breast lumps turn out to be breast cancer. However, if you discover a lump or notice any changes in your breast, it's of course very important not to ignore it. And you should see a physician for a clinical breast exam. However, there are many other causes beyond breast cancer. So wearing deodorant can cause breast cancer.
I'll do a little Jeopardy music. Okay, go for it.
Okay, so yes, this is false. So researchers at the National Cancer Institute and other institutions are not aware of any conclusive evidence that links the use of deodorant to subsequent development of breast cancer. So we'll go to our third, which is having a family history of breast cancer means that I will get breast cancer. Okay, good job, everyone. This is false. Almost everyone got this one correct. So having a family history of breast cancer can increase your risk of breast cancer, but it's not a guarantee. And in fact, most women who have breast cancer have no family history. So only about 13% of breast cancers are thought to, or 13% of women with breast cancer have a close relative. So even if you do not have a family history of breast cancer, you can still, it is still possible to develop breast cancer. So our next one is your bra can cause breast cancer. Good job, everyone. Almost everybody got this one correct, which is this is false. So underwire bras and other bras do not cause breast cancer. So a 2014 study looked at this and there was no real difference between women who wore bras and women who didn't, and those who developed breast cancer. So our next one is men can develop breast cancer. Okay, everyone actually got this one right. So this is indeed true. So while most breast cancer patients are women, over 2,000 men are diagnosed with breast cancer each year. This percentage is small, but it's not nothing. And this is, and so men also should periodically do breast exams and report any changes to their physicians. Because awareness of male breast cancer is lower than in women. And then our next question is, regular mammograms prevent breast cancer? Okay. So this is false. So mammograms do not prevent breast cancer, but they save lives by finding breast cancer as early as possible when it's the most treatable. So mammograms are a screening test, and so they detect cancer that is already present in the breast. However, they do not prevent breast cancer. Women who have had breast cancer can still breastfeed. Yep, so this one is true. Women with breast cancer with a history of breast cancer typically can still breastfeed from the unaffected breast. A child who drinks from a cancerous or previously cancerous breast will not get breast cancer, but sometimes the affected breast may not produce as much milk. It is important that if you are receiving treatment for breast cancer, you should speak to your physician before breastfeeding, and women who are receiving chemotherapy should not breastfeed. So injury or trauma to the breast, like getting hit, can cause breast cancer. Yeah, so this one is false. Trauma to the breast does not cause breast cancer. And this is our last one. So all breast cancer is the same. Yes, so this is false. Everybody got this one correct. So there are many subtypes of breast cancer, and they all require and can require different treatment. Different women have different breast cancer types with different unique characteristics. And so your own people with breast cancer all have different treatments. So in summary, by learning more, you can take control of your own health. And if you have any questions, please ask your healthcare provider. Thank you so much for your time and participation.
All right, thank you, Megan. Appreciate that. We have our next speaker, who is Dr. Liz Baltaro. She is a family physician at the Women's Clinic and medical director at the Durham VA. And we are pleased to hear from her, focusing a bit on primary care of women, I believe. So please share your screen and we'll get started.
Yes, thank you, Kathy. And I'm very honored to be here. Give me one moment to share my screen. Okay, hopefully everyone can see. So like Kathy said, my name is Liz Baltaro. I'm a family physician and women's health clinic medical director at the Durham VA healthcare system. And I am going to be
Dr.
talking.
Baltaro, we can't quite see your screen yet, so let's give it a chance to click share screen
Okay, hold
and
on.
pull that up. I know my computer had a little lag earlier this morning, but
Actually, it's not letting me share my screen. It says I'm disabled. That might be the issue.
could be. You are now the co-host. Try it again.
Okay, yes, it looks like it's letting me now. All right, thanks so much. All right, I'm going to go back here.
Yeah, someone had asked about showing the poll results, and I think it's somewhat tricky with the sharing and so forth, especially with a large group. So if there's a particular questions you wanted to know about, we can come back to that at the Q&A.
And Kathy, can you verify you can see my screen now?
I still
No.
cannot.
No, okay. The exciting adventures of
Webinars.
There we go.
Zoom. I know. Oh, are
There
we
you
good now?
go. You got it.
Right. Okay, I'm so glad to hear that. So, take 3. I'm going to be talking a bit about primary care for women's health. And given that we are now in the 19th month of the COVID-19 pandemic, I wanted to acknowledge how that impacts us, and I'll be discussing that too. So I'm really going to do a focus on self-care. So first, I wanted to start off by acknowledging the incredible mental load that we all have as women in our society. There's just so much that we're holding, and that makes it difficult to care for ourselves. I'll just speak for myself. Just to be here this morning, I had to negotiate with my husband and partner to take my 3 children out to a park so that it could be silent here so you could hear my presentation. And I'm sure that's true for, the almost 70 of us who are here on this panel this morning. It is not easy to find protected times for ourselves to think about self-care. And the COVID-19 pandemic has not made it any easier. I think, at least for me personally, and I think for many women I know, we tend to underestimate the burden and the extra stress that the pandemic has caused, but there's really a lot of extra pressures and stress on women. And I think it's important to acknowledge that now as we think about our breast health and really our whole body health. And I don't think I have them all because we probably are all well aware of how our routines have been disrupted. Again, 19 months of the pandemic. And so I think it really is even more remarkable that we're all here together today to talk about breast health. Slide I wanted to put up on the screen. I really think that many of us have heard the phrase, don't lose the forest for the trees. And I think about this a lot in my patient care, in primary care. I really try to boil it down to there's 2 things that are important to me that I feel like also are aligned with what my patients want, which is that we all want to live longer and we want to live better lives. And I love this concept of not losing the forest for the trees. Given that I'm a primary care physician, I really do usually focus on the whole body and not just one part of the body. And so I think, to simplify my message to everyone today, I would say really what's best for your breasts is what's best for your whole healthy body. And so I didn't want to get too technical with numbers, but again, thinking about the big picture, there is a very high chance of breast cancer for women and, an even higher chance of breast disease for women. But actually the risk of dying from breast cancer is about 1 in 36 women, which is not terribly high. Compared to other things like the risk of dying from lung cancer, 1 in 20 women, or the risk of dying of cardiovascular disease, which is 1 in 3 women. So to me as a primary care doctor, I kind of like to balance all of the risks and again, really try to promote a whole healthy body picture. And then, again, talking about COVID-19 virus, we are dealing now with a rising death toll that is, close to the cardiovascular risk death toll annually in the United States. So, what does this do? We're right now where we're in the midst of this pandemic and we are all dealing with lots of extra stress. I think we all know that stress is not good for our health, and we all have probably experienced in the last 19 months some physical manifestations of what stress can do to the body. So there are some obvious signs. There's also research emerging that there are connections between stress and disease, even when you account for all other factors. Cardiovascular disease has been pretty well documented. I'm not aware of studies with direct links to breast cancer or breast disease and stress yet, but I do feel like there's emerging data that, coping with stress and trying to have a whole healthy approach to situations like the pandemic are really key to being whole and healthy. So I wanted to take a second to review some healthy coping strategies. I think mindfulness practice is really important, finding ways to be present, maybe through faith-based practices or taking a moment. It looks like somebody raised their hand, and actually I'm so sorry I can't see comments right now, so if the moderator could read or let me know if there's anything important I should be aware of. I think scheduling joys and things to look forward to is very important, taking breaks from electronics, building meaningful relationships, and also making sure to get sunlight, get outside, enjoy nature. Good self-care is so important. Doing less of the things that we know are not good coping mechanisms that we all are guilty of sometimes, and more of the things that are good and healthy coping mechanisms. And then I'm just going to put up on here, related to primary care. I didn't want to bombard anyone today. I think it would be helpful to just maybe pick one thing. Obviously, if you're not vaccinated yet against COVID-19 or flu this season, flu is also, I know we tend to not think of it as much as COVID, but it also accounts for about 40,000 deaths a year, and it's vaccine preventable. So I think getting vaccinated really crucial right now. Also being body aware and breast aware. Making sure that you're caring for chronic conditions and being in communication with your doctor. So in summary, just a few take-home points that are related to primary care, in my opinion. I think we all need to be gentle on ourselves right now, given the amount that we're holding. I think maybe finding small ways, maybe pick one thing to try to be healthier at a time and coping with the stress that we're all holding right now. And then really, keeping an eye on your whole body's health, because I feel like what's best for breasts is really taking care of your whole body. Thank you
Very
again.
good. Yeah, that's excellent. Thanks so much. Sorry,
Yeah,
my little microphone didn't want to turn on. All right, thank you. And now, finally, last but not least for this hour, we have my wonderful colleague, Jackie White, nurse practitioner with the breast surgery team, and she will chat about breast cancer risk.
Good morning, everyone. Just a moment here. So as Kathy mentioned, my name is Jackie White. I am one of the nurse practitioners in the breast surgery clinic here at Duke, and also one of the high-risk providers. And this morning, we're going to be talking about breast cancer risk. The objectives for this presentation are to discuss the causes of breast cancer, risk factors for developing breast cancer, both factors that we cannot change and those that we can, along with breast cancer risk reduction. So what is breast cancer? What causes it? We actually don't know the cause of most breast cancers. Its most likely cause is related to changes in the genetic material or DNA within our cells. And some of these changes are often related to our lifestyle. Some can be due to other factors, such as age and other factors. So what are risk factors? So I wanted to just touch base on this quickly, just to kind of build a basis to this presentation, but risk factors are anything that can increase or decrease a person's chance of getting a disease. Having a risk factor or even several doesn't mean you'll definitely get a disease. It just increases your chances. It's possible for people with cancer risks to remain healthy throughout their lives. It's important to know that there are actually many risk factors for breast cancer. And as I mentioned, some of these we can change and some of them we can't. We're going to start off today talking about risk factors that we cannot change. So one being gender. Female is the main risk factor for developing breast cancer. And as many have mentioned this morning, about 1 in 8 women will develop breast cancer within their lifetime. Unfortunately, as we all age, getting older is a risk factor for breast cancer. Most breast cancers are diagnosed after the age of 50, but certainly some are diagnosed at a younger age. Family history is a factor as well. Women who have a close blood relative, especially first-degree relatives, so that's a mother, a sister, or daughter with breast cancer, or individuals that have multiple family members, either on mom's side of the family or dad's side of the family, who have been diagnosed with breast cancer. Those individuals have an increased risk of developing breast cancer. Having a male relative with breast cancer also increases a woman's risk of developing breast cancer. Certain non-cancer breast problems, such as ADH, ALH, or LCIS, also known as atypia, increases a woman's lifetime risk of developing breast cancer. History of chest radiation. So this is women who have had radiation to their chest for other causes, such as Hodgkin's lymphoma, either as a child or at a young adult, have a much higher risk of developing breast cancer later in their life. Dense breast tissue. This has been a hot topic for many women as you receive your letters after your mammogram discussing breast density. So women with denser breast tissue, specifically extremely dense breast tissue, as seen on mammogram, have a slightly higher risk of developing breast cancer. Not having children or having them later in life after the age of 30 puts women at a slightly higher risk. Having more menstrual cycles. So that means starting your periods at a young age, less than the age of 12, or going through menopause later in life after the age of 50, with the prolonged exposure of hormones, slightly increases a woman's breast cancer risk. Genetic risk factors. So these are gene mutations. Only about 10% of breast cancers diagnosed are thought to be related to gene mutations. This is something that's inherited from your parents, either from your father or from your mother. The most common gene mutations are either BRCA1 or BRCA2 mutations, but there are other mutations that are less common that are associated with breast cancer risk. These include CHEK2, PALB2, and ATM mutations, just to name a few. So when do we look at getting genetic testing? Anyone who's been diagnosed with breast cancer less than or equal to the age of 45 should consider genetic testing. Anyone diagnosed with triple negative breast cancer at any age, or a known genetic mutation within the family. As you can see here on the right with the NCC guidelines, there are multiple criteria and specific recommendations regarding genetic testing. So it's important to talk to your healthcare provider as to whether or not genetic testing is right for you or for a family member. Now we're going to turn our attention to risk factors that you can change. So as previously mentioned, physical activity, not only for your overall health, but also for your breast cancer risk. It's important to maintain physical activity. Being less active actually slightly increases your risk of developing breast cancer. Being overweight, obesity raises the risk of breast cancer, especially for women after menopause. Postmenopausal hormone replacement therapy increases with the risk for developing breast cancer. This is a complicated relationship, but most studies recommend decreasing the risk of hormone replacement therapy to less than 5 years. So greater than 5 to 10 years of therapy does have a slight increased risk of developing breast cancer. Additionally, alcohol use, the risk goes up with the amount of alcohol you drink. So there's no sure way to prevent breast cancer, but there are certainly things that all women can do to help reduce their risk. So maintaining a healthy weight, so a BMI less than 30, being physically active, at least 150 minutes of moderate activity per week. And Dr. Champ will be giving a great presentation later on this morning regarding the importance of exercise, and also limiting alcohol use. so less than 1 drink of alcohol per day. If a woman is known to be at increased risk for breast cancer, either they're due to personal history, family history, and known genetic mutations, there are some things that she can consider to decrease her chances of developing breast cancer. Chemo prevention, not to be confused with chemotherapy, is the use of medication to help reduce the risk of breast cancer. Some women who are at very high risk of breast cancer may consider preventative surgery, such as bilateral mastectomies. It's important to know that not all women are the same. Not everyone's risk of developing breast cancer is the same. So it's important to know your risk. You may have options. It's important to discuss your risk factors with your healthcare provider so that they can discuss your overall risk. There are even risk calculators that can be performed to help identify your specific breast cancer risk. So in summary, there are many risk factors for breast cancer. Some you can change and some that you can't. Every woman can take steps to reduce her risk of breast cancer. It's important to know your risk and to discuss that with your healthcare provider. Thank you again for this opportunity to present.
All right, very good. Well, we have all 4 of our panelists here and available for questions. So please feel free to type those into the Q&A area that you see at the bottom of your screen. I think Dr. Eaton is on, and I wanted to remark upon, certainly your story was remarkable, as all survivors are. But I thought it was particularly, we're hearing this exercise theme, that it's helpful for us. And I heard you say that, and I wanted you to kind of say, did it matter what kind of exercise, or was it kind of continuing what you were used to doing? And then I'd love for you to comment a little bit more about your kids and what the key was, maybe a pearl that therapist said, try this or try that.
Good morning. Can you hear me okay?
Yes.
Hi. Thank you so much for having me. It's such an honor to be here today. So with regard to the exercise, it really depended on what stage of treatment I was at. So for instance, like after each surgery, I did have to take time completely off from exercise, at least for, a few weeks. But otherwise, I just did whatever I was able to do. And I was really lucky that I had been very active before. Of course, that changed a bit with the pandemic, but I had for several years before, I'd been doing Orange Theory, which is like a combination of strength and cardio. And then with the pandemic, all those Orange Theory studios closed down. So then I'd been like running outside quite a bit. So when I got diagnosed, I was really at a very good physical fitness level, which basically meant that I was able to just keep doing all of that to some extent once I started my chemo. So I didn't let chemo get in the way. I went running like the day after chemo, for instance, the first time that I got chemo. Chemo did make me tired, so I couldn't always run as far or as fast as I had in the past, but I did it. I got a Peloton bike, which was really helpful to me, particularly after surgery, because I wasn't able to do like strength training or running after surgery, but I was able to ride on a stationary bike. So I found that very helpful. And I think a combination of strength and cardio is best, at least for me. With regard to the children, the best piece of advice that I got was to be honest. So, my initial thought was I'm going to somehow like hide this from my kids or, protect them from it. But the child life expert made it very clear that, kids have ears and kids hear things, and anything that they hear, they're going to imagine something in their mind far worse than what the reality is. So she told me to just be very honest, to use the word cancer, to explain what cancer is in a way they can understand. She led me to some books for the kids that really explain cancer on a level that's comprehensible for them. So that was really helpful as well. I mean, it was hard. There were times that, you know, I cried after talking to my kids because it really brought out my own fears. And especially like, you know, my daughter letting me know that she was terrified of me losing my hair. Like that was really hard. At one point she asked, I actually didn't need radiation. That was the one thing I didn't need through all of this. And at one time she said, could you get radiation instead of chemo so you don't lose your hair? So, you know,
And tell us, how old was she? You
she
know,
was
just
8.
8. So age sometimes matters, doesn't it?
Yeah, definitely.
Right.
It was harder for her than for my 6-year-old. And even now, you know, I do think she still experienced some trauma. Like each time that I've had to go have surgery recently, she'll say like, well, are you coming home this time? Because there was a time that I got admitted to the hospital kind of indefinitely for antibiotics and didn't come home and didn't come home. And I think that was really hard. But I think honesty with children is the best policy.
Mm-hmm. Yeah. Very good. Very, very helpful. I'm imagining, Dr. Baltaro, that you actually were pleased that she was able to get back to that exercise. I love your phrase, whole health body. I wrote it down because we all need to remember that. But I was wondering if, you know, people talk about apps to help with stress, and if you believe in apps or like Calm. I remember at one point that was free, and I love the little water dripping and you could just like pause, but it doesn't get you away from electronics. So what do you think about that?
Yeah, that's a great question. Actually, I'm so inspired to be on this panel with Dr. Eaton this morning too, and just listening to her talk about, you know, how she had to figure out exercise over the course of dealing with this. I mean, I would say to some extent, given the pandemic situation, I feel like we've all been confronted with our mortality a little bit more than usual in the last 19 months. And I do feel like that makes you kind of changes your view and your outlook on yourself and on the world. And I do feel like many of us have started thinking, especially with routine disruptions and gym closures, you know, how do we get that exercise? How do we get mindfulness practice? I don't know about faith-based communities for all of you. Ours is still like primarily virtual, and that's very difficult as well. Yeah, again, you know, how do you get away? Because I do believe that this electronic, like even the fact that we're all here on Zoom today with no in-person option, it's different, right? It's not the same kind of interconnectivity and connection that we as humans need and thrive on. So to be honest with you, Kathy, I am in the process, and I have been during the pandemic, experimenting and trying out so many different health apps. So it's funny that you ask me that. I've been doing a lot of the free trials. A lot of them have kind of a free trial before they charge you, and also trying to take advantage of all of the free things that have been offered to me as a healthcare essential worker, you know, just as an experiment. I'm always a very curious person. To me personally, I have not found any mindfulness apps to be as beneficial as being in silence with myself or with others or taking walks in nature. I feel like it is very individualized though. And I know that my own family members really do benefit from some of the mindfulness and guided meditation apps that are out there. So I don't want to speak for everyone. I mean, I think it really is important to be curious. And if things are changing and life will change and throw many things at us, you know, just to experiment and try out different things, even on a one-time basis to see if it feels good to you. But just even taking a step to kind of find that time, carve out that time for yourself, I think is the first step.
Right. I totally agree. Thank goodness for weekends if you don't work the weekend shifts. So, and I've heard of people, Dr. Eaton, who got up at 4 or 5 to get that exercise in because it was part of their time to do that. Right.
Yeah, so I'm doing that now. So I'm back at Orange. So I'm 2 months out from my surgery. So I have no activity restrictions, and I have determined that I'm just going to get back to who I was before. And for me, that means I wake up at 4:15 most days, and I take an Orange Theory class at 5 a.m. because that's the only time I can do it. But if I don't do it, then I'm not going to do it at all. But I really feel like it, even before cancer, I feel like it really changed my life. It just makes me so much healthier. And I think that the strength training is a really important component. Actually, that was something I had never done before, but I feel like it's just so good for your body to be strong. So yeah, I go to bed very early. I wake up very early. That's how I've learned to do it.
Go to bed early. That's the part I need to do more of.
Yeah.
Yes, we are still looking for people to go ahead and type in the Q&A if you have any questions. So feel free to do that. And while you're doing that, Jackie, I had a question for you. First of all, I just say it's remarkable that you already have 2022 evidence-based guidelines that you're drawing from. I saw that from the National Comprehensive Cancer Network. So that is great. You're obviously cutting edge with that. You were talking a little bit about prophylactic mastectomy. Who might be a candidate for that? Which of the risk factors might hit that category?
So the evidence is strongest in those with genetic mutations. So your BRCA1 mutation and BRCA2 mutation carriers. But certainly some women who are at an increased risk of developing breast cancer because of their family history may consider this as a risk reduction strategy as well. So it's important to talk to their healthcare provider and be referred to a surgeon who does this for a full in-depth conversation regarding the benefits and the risks of undergoing such an extensive surgery.
Right. And they would obviously also do as Dr. Eaton did and have a conversation with the plastic surgeon about possibility of reconstruction or not, depending
Correct,
on
if they're interested in reconstruction, but certainly some women do elect to go flat.
Right, right. A question for Meg Rooney. Just with the nature of technology, we couldn't see the poll results, but it seemed like the one that made the most sense that we needed to have a take-home message about was that mammograms did not prevent breast cancer, but they can help us find it early. Although an ultrasound helped Dr. Eaton. So any other comments about that, Meg?
Yes, so I think that that point, just to clarify, that mammograms are a screening test, so they detect breast cancer that's already present in your breast, but do not prevent breast cancer. So prevention strategies are more about like mitigating your risk, the risk factors that you can change. Those things may help prevent breast cancer, but the mammograms just allow you to catch them earlier. That way they are the treatment so that you can, they're more easily treated.
Right, right, absolutely. We do have a question here. This will go, I believe, to Jackie. Someone who had genetic testing about 5 years ago, and she asked, do developments since then warrant redoing the genetic testing? She had it 5 years ago.
So that's a great question. As of right now, updated testing is recommended after 2014. So 2015, or I'm sorry, 5 years ago, should be right. Sorry. Yeah. So that was
it's early.
Little math, it's a little early this morning. So should be fine, but certainly it also depends on the extent of genetic testing that was performed as well. There are some recommendations for more extended panel testing. So important to talk with either primary care or their gynecologist regarding if that is appropriate for them specifically.
Right, right. Okay, we will have one more question and then it'll be time to take the quick break. And it looks like we have a question, Dr. Baltaro, any of us may have an answer for this, so chime in. Question here from Janice, are vitamin E, dandelion tea, and/or primrose oil helpful at all for breast health?
Yeah, I'm happy to take that. And if other panelists want to add, that would be fine. I feel like as a primary care physician, I get questions a lot about herbals and supplements and various things. And I will tell you my answer. If I know that there is any evidence out there that I have read and experienced, and I try to stay up to date with all that stuff, I'll pass that on to people. I would say in general that there is not for those three that were listed, there is not any evidence that I'm aware of. And by that, I mean kind of clinical trials where they have actually tested benefits, for example, linking that with less breast cancer, for example. So, my advice to people is a lot of those things don't have big harms associated with them per se. Vitamin E actually does have a blood thinning effect. And so there are, some things to consider for patients. And again, I think you do want to make sure that you're open and honest and sharing any supplement use with doctors and asking them, because again, it's very individualized, and not everybody should be taking something that thins their blood, for example, especially if you're already taking other blood thinners. But, with that said, I feel like a lot of those don't have big risks. And so I'm not necessarily opposed, although if there's not any evidence, in my opinion, it may not be worth the money or the time or the concern that you spend. And I think that there are really well-founded and well-studied benefits of things like exercise, which also has zero harm. So I guess I really try to kind of shift the focus a little bit. I think we all want to believe that there's a pill or a tea or something that we could do that's, easy, like purchase like that. It's the snake oil thing, right? It is really tempting to think there's a quick fix. But the truth is that there's no replacement for kind of looking at your whole health and your lifestyle and the things that you do in your habits. And if other panelists want to add to that.
I'd actually love to add into this. So working in the breast clinic, we see a lot of benign disease as well. And I know that'll be discussed in the next section. Sometimes we do recommend either vitamin E or primrose oil from a breast pain perspective, but not from a breast cancer risk perspective.
Very good. Very
it's
good.
Important to note too that supplements such as those mentioned are not FDA regulated. So I always do encourage my patients to take caution in supplements and what supplements they're taking because of FDA regulation or lack thereof for these supplements.
Righto. Well, everyone, we are out of time. So much thanks for your time and energy and expertise. And we will turn it back over to our host and get ready for the next hour. Thank you so much. Have a good day, everybody.
We're going to go ahead and get started with our second session. Again, welcome to those of you who are just now joining us. Let me get my slides going here. So for those of you who are just joining us, again, my name is Jennifer Plichta. It's a pleasure to meet you today and to be today's host. Thank you again to our presenting sponsor for this event for the 5th year in a row, Invitae Genetics. Greatly appreciate their support. Just a quick recognition again to my planning committee as well. Thank you again for their input. Reminder, there will be a survey at the end of today's event. We truly value your feedback so that we can make this event to what your needs are, as this event is truly for our participants and we want to know what it is that you want to know. Remember that there will be updates posted on our website, breasthealth.duke.edu, including a link to a recording to today's event. This is where we're at in the day. We're in our second education session, which will go until about 10:50, 10:55 a.m., at which time we'll take a break. And then we'll start our third session. And then don't forget, there's going to be a more information panel at the end of today's event, starting at noon, which will be directly right here in the session. Nowhere for you to go. Just hang out right here with us. And we'll be happy to continue the Q&A part of the day for as long as there are questions. So this, again, is a little highlight about the more information panel, which will begin promptly at noon when this session ends. The next session today is going to start off with a guest speaker, Jay Baker from Breast Imaging, and then we'll talk about benign breast from Dr. Wariaks, Breast Cancer 101 with Dr. McDuff, and then breast cancer disparities with Dr. Akinye Miju. So I'd like to now introduce our moderator for session number 2, Dr. Rosenberger, who is an associate professor of surgery and the program director for our breast surgical oncology fellowship. She also serves as the chief of breast surgery at Duke Regional Hospital. She cares for over 200 women with breast cancer per year and enjoys counseling women and educating surgical trainees. She also studies rare breast tumors and has a few research trials open for women with phylloides tumors. Welcome, Dr. Rosenberger.
Hey, Jennifer, I think Dr. Dalala is moderating this session.
My
Do I
apologies.
have that backwards? Dr.
Sorry about that, Dr.
Dalala, yeah,
Dalala.
great. She's there
I'm
too,
getting ahead of
perfect.
myself.
Just had a small panic here myself.
No, my apologies. So Dr. Dalala, she is the Chief of Clinical Operations with the Duke Women's Health in Macon Pond in Raleigh. And I apologize for that confusion, but I will turn it over now to Dr. Dalala. My apologies. Dr. Dalala, we can't really hear you.
Okay. Let's see. Are we better now?
Yes, much better. Thank you.
Okay, so you're going to hear me, but you also might hear whatever's going on behind me. So my apologies in advance, but let me get right to introducing Dr. Jay Baker. And it's going to discuss radiology.
Perfect. Well, good morning, everybody, and thank you so much for inviting me to participate in this this wonderful, wonderful conference. Thank you very much. So, what I'm going to talk about is the imaging side of breast imaging care, and I'm just going to try to cover three pieces of information in my short 8 to 10 minutes. I'm going to talk about some key facts about screening. Just talk about some of the breast imaging tools that we use, the good side and the bad side, and then just touch a bit more on the issue of breast density. So let's start off with some key facts about screening. My guess is that for a group like this, I don't need to convince people that screening mammography works, but if you were curious, the data show that definitively screening mammography works. So much so that since we started screening in earnest in the mid-1980s or so, the death rate from breast cancer has decreased by about 40%. 40%, that's amazing. That means 4 out of 10 women who statistically, you know, air quotes here, should have died of breast cancer won't. They'll die, they'll grow old and die of something else because of screening. This chart kind of shows that we began screening in the mid 80s. It takes about 5 years for the beneficial effects of screening to be seen. And then you can see that steady improvement in the mortality rate. On this chart, a lower number is better. That's fewer women dying of breast cancer. And this is largely due to screening, also improvements in treatments over that time, all benefit from finding cancers smaller. So we talk a lot about the life-saving effects of screening, and those are real, but there are other important benefits to screening as well that don't get talked about as much, but are quite important also. Through screening mammography, we find cancer smaller. And when we find them smaller, that can mean far less extensive surgery may be necessary. That means fewer mastectomies, or when women choose to have breast conserving surgery, lumpectomies, that lumpectomy may be substantially smaller if their cancer is able to be found by screening. It also means that we find cancer smaller. It means fewer patients may need to undergo chemotherapy. And everything on this one slide is really crucial. The life-saving benefits, but the other benefits too are really quite a success story for screening over the decades. So the question often comes up, what about women in their 40s? So I just want to say that as Dr. Eaton has already touchingly pointed out, breast cancer is a big deal for women in their 40s. We often talk about it for older women, but it affects many younger women too. In fact, 1 in 6 breast cancers are diagnosed among women in their 40s. But because they are so relatively young, they make up about 1/3 of all years of life lost to breast cancer are from women diagnosed in their 40s. So it's a really big deal. This statistic has always been most impressive to me, that about half of breast cancers that women will die from are diagnosed before age 50. So we definitely want to start screening women when they turn 40 or younger if they're known to be at higher than average risk. And screening even young women works. So starting screening at age 40 instead of starting at age 50 saves 1/3 more years of life. So it does a lot more good to start screening at 40 than it does at age 50. We have a variety of tools to use, both in screening and in what we call diagnostic imaging. If someone comes in with a symptom, there's a long list of things that we can try to help find and diagnose breast cancer. This is just an overview of where we've started and where we've come from and where we are. So these images on the left-hand side of the screen from the 60s and 70s were the very first mammography machines. And you can kind of make out there's an outline of a breast, but not a whole lot more. In the 80s and 90s, when I trained, we used old-fashioned film that you could put up on a light box that was much better at finding breast cancer. And you can see on the right-hand side how sort of nice and clear these digital mammograms are. And that's from 10, 20 years ago. But there's still a problem. And the problem, this mammogram shows the problem. I can tell you that there is a small 7mm breast cancer, which is quite small, somewhere in one of these breasts, but you can't see it. I know exactly where it is, and I can't see it. I only know where it is because we diagnosed this years ago. So the problem is that cancers can still hide on mammograms. And one of the solutions is the new, you may have heard of it, called 3D mammograms. Technically, we call these digital breast tomosynthesis. 3D mammograms, many women think that this is what they expect to see when they walk in the room, when they hear the word 3D mammogram, but in fact, it looks just like a regular mammogram machine. And in fact, it is a regular mammogram machine, but it has been modified so that the part of the mammogram machine where the X-rays comes out moves in an arc over the breast while we take multiple very low dose images at different angles. And all those images get put back together to make a more clear picture. So here's a regular sort of old-fashioned 2D mammogram. There's a breast cancer that is present in this mammogram. And even for an expert breast imager, very hard to see. But if you look at the 3D mammogram that this patient also had on the same day, it starts to come into focus right about here. I'll just pull out the key slide. You can see this little circle with this sort of star shape coming off of it, these little sun rays coming off of it. Even to one of our first-year residents, they would recognize this as very likely a small, early detected breast cancer that is quite easy to see on the 3D mammogram and almost impossible to see on the old-fashioned 2D mammogram. It's not always that easy, but 3D mammograms definitely help us catch more cancer than the old-fashioned digital mammograms, with fewer false alarms, which is really quite important. Most of the women that we ask to come back for additional mammogram pictures from screening do not have breast cancer, but that doesn't mean we haven't terrified them first by asking to get additional pictures to make sure that everything is okay. And the 3D mammograms also have shown to lead to fewer unnecessary biopsies. That is, fewer biopsies that fortunately turn out to be benign, not cancer, but turn out to be unnecessary. We just didn't know it at the time. So that's mammograms, 2D and 3D mammograms. We also use extensively breast ultrasound. Breast ultrasound uses sound waves to literally see inside the breast. Some of the advantages are that there's no radiation when using breast ultrasound, and that's a good thing. Breast ultrasound is very good at helping us identify certain benign masses and things that occur in the breast, like this dark cyst on the left-hand side of the screen, and a couple of normal lymph nodes on the right-hand side of the screen. It's also good at helping us find masses that may be breast cancer, as in these multiple examples. You can't tell for sure that they're breast cancer, and often takes a biopsy to prove it. The problem with ultrasound, and I saw a question come up in the comments earlier, why don't we just do ultrasound on everybody, particularly women with dense breast tissue? The problem with ultrasound is that it leads to many more false alarms and many more unnecessary biopsies than mammography does. So screening ultrasound is appropriate for some women, particularly women who are at high risk, particularly if they have dense breast tissue, and particularly if they cannot get a screening MRI for one reason or another. But we think that screening MR offers more benefits than screening ultrasound, and I'll show that in this slide, actually. So another tool that we have is MRI, or magnetic resonance imaging, which also uses no radiation. In fact, it uses magnets and radio waves to make a picture of the inside of the breast. Fortunately, has no compression with it, but there is this awkward position that we ask patients to lie in for optimal imaging. And unfortunately, it does require an IV to be placed so that we can inject dye or contrast material in order to see the breast cancer. And it's not uncommon for a breast cancer to look just this obvious on MR. It's not always this easy, but sometimes it is. And you can see, even though this woman has very dense breast tissue, that doesn't show up as well on the MRI, but the cancer does. So the problem is that MRIs also have some false alarms with them. But for those false alarms, we find maybe not all breast cancers, but much closer to almost all breast cancers than we do with breast ultrasound or with mammography. And of course, the other problem with MRI is that it's quite expensive, and there just aren't enough MRI scanners in the country to screen all women if we wanted to, or if we had the money to. But for some women, particularly women at particularly high risk for breast cancer, an annual or yearly screening MRI may be an appropriate choice for her. And finally, I just want to spend just a minute talking about breast density. Jackie White already touched on this, so I will just briefly. There are basically 4 categories of breast density that you'll hear us talk about. Breasts that are almost entirely fatty replaced, have just a little bit of scattered dense breast tissue, breasts that are heterogeneously dense, and breasts that are extremely dense. Only about 1 in 10 women have breasts that are almost entirely fatty replaced. By the way, you cannot tell by physical exam, you can't tell by looking at a patient, you cannot tell by age. You really can only tell by a mammogram how dense the breast tissue is. So some women hear this almost entirely fatty and they're not real pleased with that description. From my perspective, this is what we like to see. It makes finding breast cancer much, much easier when the breast is fatty replaced. About 4 out of 10 women are scattered, another 4 out of 10 women heterogeneously dense, and only 1 out of 10 women have the most dense breast tissue or extremely dense. So when we talk about women who have dense breasts, we're really talking about the half of women, 50%, who are either heterogeneously dense or extremely dense. So having dense breast tissue is not rare. It makes up a half of women. And you can see that finding a breast cancer like this one in an extremely dense or even a heterogeneously dense breast can be quite challenging. So there certainly is an issue of women with denser breast tissue having increased risk, and you may even hear numbers up to a 3 or 4 times risk. That actually isn't correct. The 3 or 4 times risk is the 1 out of 10 women with extremely dense breast tissue are at increased risk over women who have almost entirely fatty breasts. But that's really the comparison of the extremes. If you compare just women with dense tissue with women who don't have dense breast tissue, this is a much smaller increased risk. The numbers may look large here on the screen, about 20% to 2 times the risk, but that's really quite similar to the range of risk from taking birth control pills to being overweight. So, and there's not much you can do about your breast tissue density. So just in summary, I just want to reiterate that screening does save lives. We do not find all breast cancers on screening. That is absolutely true, but over a population of women, screening absolutely saves lives and saves years of life, just as important. We have lots of tools at our disposal to help us find cancers and find them early. And density is important, it does matter, but it's not everything. And I look forward to answering any questions in the question and answer session later. Thank you.
Thank you so much, Dr. Baker. That was great. I'll throw in a personal. I tell my patients, it's not an awkward position for an MRI. It's like you're having a massage, and that positioning, and not everyone's experienced that, but sometimes they can relate. Anyway, thank you so much. That was very informative, and we're going to move right along to welcome Dr. Hannah Wariaks, who is a recent addition to our breast surgery faculty. We're delighted to have you. And again, not everything is breast cancer. The title of this full symposium is What's Best for Breasts, and there are many benign breast issues. I won't call them diseases, issues, and Dr. Wariaks is going to speak about them. Thank you so much for joining us.
Thank you, Dr. Delala, for that wonderful introduction. Good morning, everyone. Thank you for spending your Saturday morning with us, learning and empowering yourselves about your breast health. I'm going to share a little bit about benign breast conditions with you. Can everybody hear me fine?
We can, thank you.
Excellent. Just a few things that we're going to go over this morning. We're going to talk a little bit about breast pain, and I know that's a pretty large topic, but we'll try to hit the highlights. We'll go over 2 different types of breast infections and who they really, who experiences those and how we treat them. We'll go over nipple discharge, breast cysts, and fibroadenomas, which are a type of benign breast mass. So when we talk about breast pain, a lot of times it's really important for us to tease out for women whether it truly is breast pain or whether it's pain from somewhere else. A lot of times we'll feel things and they feel as though they're in our breasts, but they can be related to the chest wall itself. A lot of times we can have pain within our chest related to our lungs or other organs that can also feel like breast pain. So it's really important when we see someone and that's their complaint for us to tease out whether or not it specifically is the breast, and if it is, which breast is affected, and then tease out some other details that can help us in that patient's treatment course. So one of those questions is it related to our cycle or not? And if that woman's premenopausal and still experiencing their periods regularly, sometimes that's very easy to tease out. They can say, oh yeah, I can tell you right before my period starts, this is when I have my breast pain. Unfortunately, it's not always that simple, but it's our job to sort of go through that with you. And if there are certain things that we can identify for you that can help with your breast pain, such as not wearing a very structured bra, and you notice when you do wear a structured bra, that pain is better. Noticing that on days where you have more coffee, maybe you have more pain, things related to that, that we can help you tease out in the office that can really impact women's life when they truly do have breast pain, because anyone who's experienced true breast pain before can tell you it's not just simply a nuisance. For some women, it can interfere greatly with their day. Some other things that we can try if we can identify that women do have specific breast pain, but not necessarily an identifiable factor that we can modify. We can do simple NSAID therapy for patients that are candidates for that and see if that can help with their breast pain. There are some supplements, I know people have mentioned primrose oil before in our discussions. Some people have tried that and had anecdotal responses. So there are things that we can try with patients to sort of mitigate that pain in a way if there are more nondescript or not simple identifiable factors that cause the pain itself. When we look at breast infections, patients come to us with breast infections that are caused by multiple different things. The most common thing that we see a lot of times is lactating women can develop breast infections. And anyone that's breastfed in the past or had issues with lactation, people warn them about mastitis, or it's something that's fairly known about in the breastfeeding community today, at least. And what this is a gross inflammation of all of the breast tissue, or what feels like at least all of the breast tissue in one breast. It's usually unilateral and is usually related to breastfeeding itself. The treatment is multifaceted, and for most patients, the most important thing is controlling the pain, because a lot of the other portions of the treatment will not work well if the pain is not well controlled. We also treat this with antibiotics. Usually patients get a 10-day course, but that can be altered for patients and depending on how well they do. And a lot of times this involves continued breastfeeding, especially on the affected side, or pumping and dumping, whatever the patient chooses to do in coordination with their provider. And that's why pain control is very important for these patients. Infections can cause quite a bit of pain in any portion of the body, and specifically in the breast. It's important for us to treat that adequately. The more severe infection or more concentrated infection is termed an abscess. So essentially what that is a collection of pus within the breast in one specific location. And the important difference between the two is that an abscess needs to be drained. That's part of its treatment plan, is that we have to drain that abscess. We have to get that infection out. And usually this is done by aspirations, which can be done multiple different times. Hopefully one treatment would be enough, but we can do this several times, either in the office or depending on people's pain. If they need this done in different locations, we can at times do it in the operating room. Rarely we do have to incise these or drain it with surgery. And it doesn't necessarily have to be surgery in the operating room, but aspirating it with a needle and just getting the pus out that way won't necessarily help every single time. And then we also do antibiotic therapy for this type of infection as well. The most important thing about abscesses is that they can recollect. So it's very important that these patients also have scheduled follow-up with someone who's managing this for them. And that way we can guide your course of therapy to make sure that we've eradicated it fully and that it's not reaccumulating and that this won't be a chronic problem. Sometimes people do have recurrent abscesses. They come back time after time, and that can be related to lots of different things. It can be related to lactation. It can be related to smoking and other risk factors that we can try to help patients mitigate. But that's why follow-up is important for these, so that we can make sure once a patient is treated, that treatment was adequate. And if they need any follow-up, such as imaging or other things, that we can arrange that for them as well. Nipple discharge is a topic that makes a lot of people uncomfortable, and usually if people see nipple discharge, they immediately get frightened unless it's related to lactation, which can be disconcerting the first time if patients have never lactated before as well. So there are lots of different types of nipple discharge. For the most part, nipple discharge in and of itself is usually benign and not necessarily related to a cancer. It can be clear in color, it can be a yellow or a green color, or it can be blood tinged. And those can tell us something about where this may be located, but none of those things are absolute. There's pathologic nipple discharge and physiologic nipple discharge. What are the difference in those two things? Pathologic nipple discharge is usually unilateral, and it's usually related to something within that breast that's caused that one breast to have nipple discharge and the other breast is completely unaffected. Physiologic discharge is usually in both breasts, and it's related to something that the body is experiencing as a whole. Both need to be investigated, and there are several questions that we can ask that help us delineate one over the other. The obviousness of one breast versus both breasts can sort of help guide us in one direction or another with patients. But there are some other things that matter as well. Whether that nipple discharge is spontaneous, if women just have discharge that they notice within their bra and they've had no trauma to the breast or haven't expressed anything purposefully, that's spontaneous discharge. And expressed discharge is a discharge that you make happen with your physical exam or that you can initiate yourself, but it does not happen on its own. The other thing that we can examine patients for in clinic and identify is whether there's one duct involved or several ducts involved. And a perfect example of that, of several ducts, is lactation. For a woman who's actively lactating and ready to express milk, a lot of times if you express anything from the nipple, if you press on the breast, you will see milk come out of multiple different places within that nipple. That essentially means that there are several ducts involved in that process, and it's not just one specific duct. The other thing that's important is timing, right? So if it's related to one specific thing or a time in the month, if women are still on their cycle, that's also important. the question is, what do we do for patients that have this nipple discharge? Well, we investigate it in one way or another. Usually that's done with imaging if there's not something that's obvious clinically to explain the discharge is physiologic in nature. And a lot of times that will be several different types of imaging. You may need a mammogram, you may need a ductogram, you may need an ultrasound, but we do our best to get to the bottom of the discharge with the patients in a way that involves both parties and working out a way that's easy to facilitate what's going on. So, and then the other question is, how do we treat this? And that's also something that involves both you and your physician, or you and whoever you're making this decision with. So a lot of times these can just be followed if they are benign, and we do have a cause for them. And sometimes patients want whatever that cause is excised if it's a mass or something within a duct that's causing enough irritation that it's causing that discharge. Patients want that excised for to help with anxiety and calming their minds. So it's important that when we've identified this, we also come up with a plan that makes everyone comfortable for how to manage it. Breast cysts. So you may hear a lot of people say that they know that they have a cyst in their breast. And a lot of those patients will tell you, I can feel it change in size over the course of my cycle or over the course of a few months. They're essentially felt like masses in the breast, or they are seen on routine imaging and patients didn't know prior to that imaging that they had them. The thing that we look for when we've identified a cyst is whether that's a simple cyst or a complex cyst. And the way that I like to think about it is whether it's a single collection. So you look at that cyst and you can tell that there's one type of thing in it, whether that be a liquid or a solid component, or whether there's a complex cyst which has multiple different types of components. So liquid and more solid features within the same cystic structure. And like I spoke about, it can increase or decrease in size. And some people can have several within the same breast or several on both breasts. And the question is whether we follow or treat these as well. They can be treated in multiple different ways. They can also be excised or aspirated. And we can follow them with imaging if patients don't want any intervention, or with clinical breast exam. Fibroadenomas. You may hear some women speak about having fibroadenomas, and similarly, like breast cysts, these are also felt as a mass in the breast. And the difference is they're made up of glandular or stromal tissue or epithelial tissue. You may hear some people refer to it in that way. And the difference in the two is that these can increase in size, but they never really decrease in size. They can also be numerous, just as breast cysts are. And sometimes you need a biopsy to determine that this is absolutely what you're feeling, to make sure that that mass is truly a fibroadenoma. For women that have this and it grows pretty rapidly, they can have it excised, or if it's symptomatic in any way, we can discuss excision of a fibroadenoma. Some patients have fibroadenomas that are followed on imaging and they don't grow rapidly, they don't really change much in size, and we can follow them with imaging alone. So what do we do? How do we empower you?
Thank you, Hannah. I'm so sorry to interrupt,
okay.
but we're a little short on time. We'll
Sure.
keep it along, and we'll catch this back in our questions.
Okay.
Appreciate the great information, and we're going to move right along because I know we want to make sure that we have some time for questions at the end. And appreciating Dr. Susan Duff, radiation oncologist, assistant professor in the Department of Radiation Oncology, who's going to talk to us about Breast Cancer 101. Thank you.
Hey, great. Thank you so much for being here today and for having me. I'm just really excited to give a short segment here on Breast Cancer 101. So I'd like to the goal for this segment is to try to explain what breast cancer is and to try to talk in general terms about the treatments that we use for breast cancer. And so first question, what is breast cancer? So cancer is a process where a small focus of cells have developed the ability to grow when they're not supposed to. And so cancer cells keep dividing and dividing and dividing. And if they're not treated, they can unfortunately basically take over and start to harm some of the normal cells and structures in the area. And as you know, unfortunately, breast cancer is the most common form of non-skin cancer in women. And 2021 isn't over yet, but they have estimated that about 280,000 new invasive breast cancers will be diagnosed this year in the US, and nearly 50,000 pre-invasive cancers. So also men can get breast cancer too, and about 2,650 cases will be diagnosed this year. So unfortunately, that means that about 1 in every 8 women in the United States will develop breast cancer in her lifetime. And so let's just jump right into breast cancer basics. So not all breast cancers are the same. And I think that one of the amazing things is how differently a breast cancer can behave. And there are 3 sort of big areas that we look at to try to understand the behavior of the breast cancer and the treatment for the breast cancer. So we look at the stage, which we'll talk about in a few minutes, and the grade, and we also look at biomarkers for the breast cancer. So importantly, not all breast cancers are the same, and not all treatment courses are the same for breast cancer. So most patients do need surgery for their breast cancer, but some patients need chemotherapy or endocrine therapy. Some patients need radiation, and all of that really depends on the features of the breast cancer and also features of the patient as well. And so types of breast cancer, there are 2 sort of big types of breast cancer, and I divide this into pre-invasive breast cancers and invasive breast cancers. So the breast is made up of areas called lobes, and the lobules make milk, and the milk is taken to the nipple by way of these ducts. And most breast cancer cells start in the duct. So a normal duct should be nice and open like this to allow milk to flow through. So the duct has a nice wall, and there are normal cells that should be lining the duct like this. And breast cancer cells, when they develop inside the duct, can start to take over and block the duct. When breast cancer is diagnosed at this stage in situ, that means that the breast cancer cells, even though they're cancer cells, they haven't developed the ability to invade beyond this membrane and possibly cause problems. But when they are allowed to, or they're long enough and break through the membrane, that's what we term as an invasive breast cancer, one that has broken through and invaded into the surrounding breast tissue. And unfortunately, in this state, cancer cells can then continue to grow and take over more areas in the breast, possibly spread to lymph nodes, and then possibly spread to other areas of the body. So breast cancer staging, this is a really big kind of important thing we think about when we first meet a patient with breast cancer. And we're thinking about how big the tumor is, the areas involved, and those really do influence the treatment recommendations for our patients. So T is for tumor, so that refers to the size of the tumor. Non-invasive breast cancers are classified as TIS, or in situ. Invasive breast cancers can range from 1 to 4, related to the size of the tumor and whether there's any involvement of skin or muscle. N is for lymph nodes, and clinically we can assess how the lymph nodes feel, how they look on scans, maybe do a needle biopsy for them, and then after surgery we can understand pathologically was there cancer in those lymph nodes that were removed at surgery. And M is for metastasis, so this would indicate that we know that disease has spread elsewhere outside the breast and regional lymph nodes to another area of the body. So that's staging, and histology and grade is another feature. So histology is what type of breast cancer is: invasive ductal, lobular, and grade, it refers to how aggressive the cancer cells look. So to determine this, we need to take a sample of the tissue, which is done via a biopsy, and the tissue is taken to our lab, and we section it and put it under this microscope and look and zoom in, and how aggressive do the cancer cells look. And they're graded low grade, intermediate grade, or high grade. And low grade cells tend to look a little more like normal breast cells, and just like they're going to behave a little less aggressively compared to high grade cells, which have divide faster and tend to look like they'll be a bit more aggressive. So biomarkers are really important. Anytime we have a new breast cancer that's diagnosed, we look at 3 main biomarkers: the estrogen receptor status, progesterone receptor status, and HER2 status. And these are the really critical aspects of breast cancer cells that will help us guide treatment. So if the receptors for estrogen and progesterone are present, then we know that those cancer cells will be fueled by hormones, and we can use anti-hormone therapy to decrease the growth or risk of the cancer coming back. And also these biomarkers help us understand what some of the systemic options will be. So I like to think about breast cancer treatments as local therapy therapy and systemic or whole body therapy. And here at Duke, when we meet a patient with breast cancer, we think it's really important to, at the very beginning, when patients are first diagnosed, to actually have you meet with all three members or all three teams that may be involved in your care. So your surgeon, a radiation oncologist, and a medical oncologist, to talk about the big picture and try to anticipate what treatments would be needed along the way. So surgery, there are local treatments, obviously local treatment for breast cancer. So patients can have surgical removal of the breast cancer either via a lumpectomy or a mastectomy. And it's also really important to manage or treat the axilla, either to understand if the cancer is spread to some of those first draining lymph nodes by a sentinel lymph node biopsy or an axillary lymph node dissection, often for patients that we know have cancer that's spread to the lymph nodes. And often after lumpectomy, we need radiation as part of breast conserving therapy. And we sometimes still need radiation after mastectomy, basically to target and kill any microscopic cells that might remain in the area after surgery, but that's still a local treatment. And systemic therapy is an incredibly fascinating area so we have many different ways to target breast cancer. So we can use either endocrine therapy for patients that have what we call hormone receptor positive cancers, or targeted therapy for patients with HER2 positive cancers. We can also use chemotherapy, and now more increasingly immunotherapy, to try to help the body's immune system fight the cancer. So just a couple pictures about surgery here. So a lumpectomy, it consists of when these amazing surgeons that I get to work with go and remove the lump and a small rim of surrounding tissue, but leave the breast intact. And this is really a wonderful option for patients that have small tumors that are located in just one part of the breast. Sometimes women may choose or may need to, if they have more extensive disease in the breast, have a mastectomy, which involves removal of the entire breast. And then here's a picture about radiation. I saw a question in the chat. I'll spend a minute trying to address that here, and then happy to talk about that in the Q&A. But radiation is a very targeted treatment for breast cancer that uses high energy X-rays that we make from a machine called a linear accelerator. So we design these radiation plans to be very specific and conformal to each unique individual patient. And this is a picture of a patient who is getting radiation to her left side. And the first thing to note is radiation isn't actually red. You can't see it, but for the purpose of this picture, we're trying to angle the radiation very steeply to avoid, if you could look at a snapshot where this at the level of the cancer, to really avoid the heart and lungs. And to address the question in the chat, we've come a long way in the last 20 or 30 years to help protect the heart for women who are getting radiation, and in particular using what we call three-dimensional radiation planning, but also more importantly, having patients do a breathing technique or holding their breath, particularly on the left side. So when patients take in a big deep breath, that expands their chest and really pushes the heart down in a way. And I'm happy to talk about that further. And so then switching to, and so talk about that further in the chat later, but so switching to systemic treatment for breast cancer, just to highlight endocrine therapy, this is a really important type of hormone therapy that prevents estrogen and progesterone from helping breast cancer cells grow. Patients can do this by either taking a medication, or premenopausal patients can have ovarian suppression or surgery to remove the ovaries. Chemotherapy is often needed for patients with HER2 positive disease, triple negative, or node positive disease. And for patients that have hormone receptor positive or HER2 negative cancers, we can use these wonderful tests, either the Oncotype or the MammaPrint, and there are others to help us figure out who might benefit from more intense chemotherapy. And then targeted therapy like Herceptin can help target patients with HER2 positive cancers. And then now more increasingly, we're using immunotherapy to help the immune system learn to fight those cancer cells. So to summarize, unfortunately, breast cancer is very common, but the vast majority of patients that we meet, as Dr. Baker pointed out, with advances in screening and catching patients earlier, we are able to cure this disease for most patients that we treat. And every breast cancer is different. So if you hear of someone or a family member or friend going through breast cancer, and they've gone through a certain set of treatment, that doesn't necessarily mean that would be what would be recommended for you. And so we look at a number of different factors, and we get to know patients and their preferences and their values in coming up with a treatment course. So every treatment course really is truly unique, and treatment depends on the size, location, biomarkers, and as I said, patient values. So if you or your loved one is diagnosed with breast cancer.
Thank you so much. I really appreciate the presentation, Dr. McLaughlin.
Yeah, thank you.
Thank you. And finally, for this block, we have Dr. Tomi Akinamichu joining us. She is social and molecular cancer epidemiologist and is going to talk about breast cancer disparities. And we'll try and leave a couple moments for questions at the end, and certainly you can put them in the chat. Thank you.
Thank you so much. And I'm really excited to be here joining you all this morning. Really appreciate all the really excellent talks so far today. It actually ties in very well with the topic I'm going to be discussing, which is focused on breast cancer disparities. And just to start out by saying that breast cancer is the most common cause of cancer among Black women in the US, accounting for about 32% of all cancers diagnosed in Black women. Incidence is higher nationally, so the number of new breast cancer diagnoses is higher among white women, but in certain states, including in North Carolina, it's actually higher in Black women. And the main focus of this talk will be on Black-white disparities, although we recognize that there are disparities in outcome that affect other race, ethnic, and socioeconomic groups as well. But for breast cancer, we really see striking differences in mortality, where even though there has been really rapid advancement in treatment strategies, as was mentioned earlier, including chemotherapy and immunotherapy, we still see that Black women are about 40% more likely to die from breast cancer compared to white women. This difference, this racial gap has been documented since the 1980s, and unfortunately it still persists till today. So we think that that disparity is likely due to several factors, right? Differences in early detection. We've heard a lot about screening, tumor aggressiveness. We just heard about biomarkers and understanding the kind of features of the tumor itself, and differences in access to treatment. We know that Black women are more likely to be diagnosed when they're younger and to have the triple negative hormone type, which has poorer outcomes. Regarding early detection, we see differences by race, where African-American women are more likely to be diagnosed at distant stages. So that's getting at issues related to early detection and screening, which, as we heard earlier, is really critical to make sure that women are diagnosed early and have the best treatment outcomes. We also see that, across all racial groups, that Black women are more likely to be diagnosed with a hormone receptor negative subtype. So that's a subtype that's believed to be more aggressive, and the treatment options are not quite as effective as other types. So these two factors, are, really striking in terms of explaining the racial gap in breast cancer outcomes. But we've also begun to understand that beyond the individual and the biological factors that may contribute to the disparity, that there are really wider societal conditions that also impact the disparities that we observed. So we're doing a lot of research now focused on not just the risk factors that we understand, alcohol, obesity, physical activity, but also social factors such as socioeconomic status, healthcare access, and kind of societal factors when we talk about structural racism, and how those have impact on biological mechanisms. So our chronic stress and kind of obesity and inflammation, and biological factors that we know are associated with the risk of developing certain subtypes and having tumors that are that progress faster, and those all explain the cancer disparities. So we're beginning to do a lot of work moving beyond the individual risk factors that we know are important, but considering broader societal factors as well. We're also thinking a lot about how the ancestral environment, so for women of African descent, has an impact on their immune response, in such a way that, back prior to the Atlantic slave trade that moved people of African descent to the Americas, that there is biological features that evolved to adapt to the local environment there that may have changed as a result of migration and now residing in non-ancestral environments. And we think that there are changes in either our genetic markers, our immune response that have an impact on, how cancer develops, what type of cancer develops, response to treatment and mortality outcomes as well. So thinking, again, as part of the societal factors as not just the, environment that we live in now, but environments that we used to live in centuries ago, how that may have an impact on health outcomes. And really the purpose of thinking about those broader factors and the biological factors is so that we can identify specific mechanisms that can then be the focus of either treatment, lifestyle intervention, and other strategies to reduce the disparity. So here on the left, it's showing when we compare breast cancer patients with healthy women, and then we're looking at those that have metabolic syndrome, which is a combination of having obesity, high blood pressure, diabetes, and other metabolic conditions. We see that those that have metabolic syndrome are almost 4 times more likely to have the triple negative subtype, which I mentioned earlier as being more common among African-American women. So this is what we're finding in our research. And the way that we can translate that to interventions is we know that metabolic syndrome, again, obesity, hypertension, insulin resistance, there are both lifestyle in terms of physical activity, diet, alcohol, and clinical interventions such as metformin and other agents that we can use to address that issue. And looking downstream, we can see that reducing metabolic syndrome, has an impact on reducing the risk of breast cancer and the triple negative subtype specifically. So this is just an example of how the research that we do, looking at population level and patients and looking at characteristics that may be more prevalent or unique to racial subgroups, can help us identify interventions that can help us reduce breast cancer in those populations. And so again, just wanted to summarize, we've heard a lot of this today already, that there are several risk factors that is under our control to help us reduce the risk of breast cancer. Healthy weight, exercise, limiting alcohol. Those are things that we can control ourselves. There are other risk factors that we can't really change. Race, ethnicity is one of those, but through research, we can understand what are the factors that are associated with race, ethnicity, whether it's lifestyle, whether it's societal conditions, whether it's a genomic factor. And once we understand what those are and how they affect the development and progression of breast cancer, we can then design interventions to reduce those. And currently, it's widely understood that by addressing the risk factors that we already know lead to increased risk of breast cancer, that we can actually prevent about 1/3 of all cancers and about 33% of breast cancer. So there's a lot within our control in terms of preventing breast cancer from developing in the first place that we can all work on. And then thinking about how we move the field forward, again, the 40% difference in mortality, where Black women are more likely to die of their breast cancer compared to white women, is a focus of really rigorous research. And we're looking at improving access to treatment and screening and prevention. And we're trying to understand the biology of factors that lead to breast cancer so that we can intervene at that point before breast cancer develops, and that women have access to screening so that we can catch the disease early before it progresses. And that once the breast cancer is identified, we can link patients with really cutting edge advanced treatment to improve outcomes. We're studying the environmental and the biological contributions to cancer and how those might be unique in different racial groups. We are working to include samples from really diverse populations. We need more African Americans, more Hispanic women, more American Indian populations to participate in research and clinical trials so that we can again understand how the disease might be different in those populations, so we can better tailor our treatment strategies. So just to conclude here that many factors contribute to the higher breast cancer mortality in Black women. We're doing a lot of work to understand the societal, the physical, the lifestyle, the biological mechanisms that contribute to that disparity. That will help us target our prevention and treatment strategies so that it's more effective for those populations. We really are doing a strong focus on healthcare access disparity so that women get access to breast treatment. And there's a lot that we can do now to prevent breast cancer from developing currently. So with that, I will stop and take questions. Thank you.
Thank you so much, Dr. Akinamichu. We really appreciated that presentation. We have just a couple of minutes for questions before we go to our short break. Please note you can put questions in the Q&A and we'll try and answer those for you in the Q&A if they're not particular. And I think I'm going to throw out a question that I'll direct at Dr. Wariax, but any of the panelists can chime in. Dr. Wariax talked about pain control. I think it was particularly in patients with breast abscesses, but patients can have pain for lots of different reasons, and we try and avoid narcotic pain therapy. So I'm interested to hear pain treatment strategies.
I think one thing that's imperative that we identify is the type of pain that patients are having, because a lot of times that will guide our pain strategy. Sometimes it can be a neuropathic pain, and we can use neuroactive medications to help mitigate that pain. And a lot of times it's an inflammatory pain, and we can use NSAIDs like ibuprofen or Tylenol to help with those types of pain that women experience. So it really depends on the type of pain that they're experiencing. And if we can help delineate which specific type it is, then we can better treat it, or we'll usually start with something general like an NSAID.
Thank you. Any other thoughts? There's a question in the chat for Dr. Akinamichu. What would be your advice for other providers and health systems to help eliminate these healthcare disparities and increase access to care? Excellent question.
Yeah, that's a great, really complex question. We know that there are, again, very several factors that contribute to health disparities. But in terms of access specifically, we can think about affordability, like the socioeconomic status and how that impacts who has insurance, the co-pays that they have to come up with. We can think about transportation access for those that live in rural areas and need, to find their way to the hospitals. So I think we can do a lot in terms of our policies as healthcare providers and healthcare facilities to reduce the barriers there, where we're working with patients to help them find financial support to afford care. We're doing a lot with telemedicine so that people don't have to drive hours to come with us, and just being more flexible and providing more resources for patients to address some of those barriers.
Thank you. And we've gone just a couple minutes over our time, and I think there's a break, and I definitely want to stay in. So Dr. Plichta.
Yep. Thank you everyone for tuning in for session number 2. We're going to take a short break here. Give me just a minute, but please come back and join us again in about 5 minutes. Thanks, everyone. Okay, we're going to be getting started here in just a minute with our third session. Give me just a second to pull up my next slides. Of course, my computer is on overload, so give me just a moment here. There we go. All right. So thank you again to everyone for joining us this morning. Really appreciate all of you that have tuned in this morning to hear more about how to best take care of yourself and your breast. Again, for those of you just joining us, my name is Jennifer Plichta and I'm the host for today's event. Thank you again to our presenting sponsor, Invitae Genetics, without whom this event would not be possible, and they have been our sponsor for the last 5 years, so sincerest thanks to them. Remember, there will be a survey at the end of today's session, so please do fill that out. We do appreciate your feedback, and it will help us better plan this event for next year. Remember that you can find updates about ongoing breast events on breasthealth.duke.edu. There will also be a link there to a recording for today's event. This is where we're at in the day. We've reached our third and final education panel where we'll have 4 more fantastic speakers, a final Q&A session, and then don't forget at noon following this session, there will be a more information panel where some additional guest speakers will join us to answer more questions that you might have, purely just some additional time to get questions answered. So this final session today, we'll start off with survivorship, and then we'll talk about exercise. We'll have a great presentation on local resources and access, and then we'll finish up with a talk related to breast cancer research. Apologies again to Dr. Dalala, who was our fabulous moderator for the second education block, but this time it is truly going to be Dr. Laura Rosenberger, who will be moderating session 3. She's an associate professor in the Department of Surgery, and she's also the program director for our Breast Surgery Oncology Fellowship, and she serves as the chief of breast surgery at Duke Regional. She cares for over 200 women with breast cancer each year and enjoys counseling women and educating surgical trainees. She also studies rare breast tumors and has a few research trials open for women with phylloides tumors. And so with that, I will go ahead and turn it over to Dr. Rosenberger.
Thank you, Dr. Plichta. So in the background, I'm just getting some slides ready, but without further ado, Dr. Kelly Westbrook will be our next presenter. She is a breast medical oncologist. She's an assistant professor of medicine and practices here at the Duke Cancer Center in the Maine University. She runs the Duke Sexual Health Program for survivors of women's cancers, and she cares for nearly 1,000 women with breast cancer per year. Her research is focused on patient symptoms on and after medical treatment for breast cancer and managing their side effects, and she'll be presenting today about survivorship. Dr. Westbrook, would you like me to share those slides for you?
Dr. Westbrook, I was just able to make you a panelist, so hopefully you should be able to share now. Bear with us, please, participants, as we navigate this small technical difficulty. Should be just a moment now.
I am trying to share. It's, can you all hear me?
We can.
Yes.
Okay. Can you see me?
We can see a green screen.
And Kelly, if you
wrong.
If you would like me to advance slides, I have your slides now, so I'm happy to try and share my screen.
Okay. Why don't we do that? Because I'm not sure what's going on, but it's not.
Dr. Plichta, can you see Dr. Westbrook's slides?
I can.
Great.
Thank you.
So Dr. Westbrook, I'll advance if you just want to say slide advance.
Okay, perfect. Well, now I'm just so sad I put on makeup for this.
Oh.
I'm so sorry, everyone. But thank you so much, Dr. Rosenberger, for sharing these slides. So we will just really quickly talk about breast cancer survivorship. And if you want to go ahead and advance to the next slide. As a medical oncologist, I often get asked, when do I become a survivor, or what makes me a survivor? So just very generally taken from Webster's dictionary, a survivor is someone who remains alive and continues to function during and after overcoming a serious hardship or life-threatening disease. In cancer in particular, a person is considered to be a survivor from the time of their diagnosis through the balance of their life. And this comes from the National Cancer Institute Dictionary of Terms. We do know that 1 out of every 8 women will have a chance of being diagnosed with breast cancer over the course of their lifetime. And although we don't like this statistic and we want it to be even better, still only 1 out of every 37 women diagnosed with breast cancer will die from that disease. So the vast majority of breast cancer diagnoses are in people who will go on to live a life that will not end from their breast cancer. So there are very many breast cancer survivors alive in the US. And if you'll go ahead and advance to the next slide, this graph on the left comes from the SEER database from 2016 census data, and just collates a lot of census data to look back over the decades at how the number of survivors in the US has grown. And this is including projections over the next 20 years to show that in the year 2040, we estimate that there will be more than 26 million Americans alive who have had a diagnosis of cancer. So many cancer survivors in the US. And if you'll click one more, this shows the breakdown of the current, or at least at the time of the last analysis in 2019, numbers of cancer survivors in the US by disease site. And you can see that the vast majority of cancer survivors alive in the US are breast cancer survivors. So there are currently almost 4 million breast cancer survivors in the US. If you'll click to the next slide, just to talk a little bit about what is survivorship, I put up a couple of quotes from some of the National Cancer Institutes. And in general, cancer survivorship is the focus on or practice of maintaining the health and well-being of a person with cancer from the time of diagnosis until the end of life. This includes the physical, mental, emotional, social, and financial effects of cancer that begin at diagnosis and continue through treatment and beyond. The survivorship experience also includes issues related to general follow-up care, such as regular health and wellness checkups, late effects of treatment, cancer recurrence, second cancers, and quality of life. Family members, friends, and caregivers are also considered part of the survivorship experience. If you'll click to the next slide, when we think about the practice of survivorship from a medical standpoint, we try to think about 3 phases of survivorship. Acute survivorship starts at the time of diagnosis and goes through to the end of initial treatment. And at that point in time, treatment of the cancer is the focus. Extended survivorship would be the phase after the end of initial treatment and ongoing through the months after. And at this point, we're focused mostly on the effects of the immediate treatment. And sometimes some extended treatment is ongoing. And then permanent survivorship would be the time years after diagnosis when all treatment has ended and there is less of a chance that the cancer may come back. And at that point, we are still following patients and the long-term effects of the cancer treatment is the focus. If you want to move to the next slide, this is a little bit of a busy slide, but I think it really accurately represents the process of survivorship. And this is one of my favorite quotes over on the side. It was published by a woman who is a breast cancer survivor and also a physician. And she really accurately stated what many patients feel. After I finished my cancer treatment, my doctors discharged me and expected me to be happy. Instead, I felt alone and scared. We see often in the practice of breast oncology that when we have the phase of active survivorship, patients know when to come to the cancer center. They know what they're supposed to be doing. The time of active survivorship is very busy. And then when you finish active treatment, you're not coming in as regularly. You may not even be seeing your regular doctors. And it is frightening. So our job in survivorship is to create more of a clear path for how to deal with all of these issues. If you want to go on to the next slide, acknowledging that this is a significant issue, the Institute of Medicine came out with a very long report in 2005, actually, trying to address the needs of survivors. And so they came out with requirements for components of survivorship care, and cancer centers are held to these requirements to maintain their accreditation as a cancer center. And adequate survivorship care, without reading through this entire slide, I'll just try to encapsulate that it's thought that adequate survivorship care should address prevention of recurrent and new cancers. It should address surveillance for cancer spread and recurrence, assessment of medical and psychological late effects, which is so crucial, intervention for those late effects, and then the last bullet point, perhaps the most difficult, coordination between all of the specialists involved and the primary provider to make sure that we meet all of these complex needs. If you want to advance to the next slide, this is a very busy slide, but I like it because I think it really adequately addresses how complex all of this coordination is. It is, however, extremely crucial that we communicate with one another, because that is the only way that all of these survivorship needs can be met. If you can go ahead and advance to the next slide. We won't go through this all in detail, but I like it because it really helps to summarize the fact that every modality of treatment for breast cancer has significant issues that can be long-term and late effects of that treatment. And all of these are things that we have a goal of assessing for in follow-up visits and taking care of if they are identified. And so these are all of the things that breast survivorship care should be encompassing. If you want to go to the next slide, this is data from a survey of breast cancer and prostate cancer survivors that was administered through the Livestrong Foundation. And Livestrong is a wonderful foundation that does a lot of survivorship advocacy, but these are patients who were surveyed at the 5-year mark following diagnosis. And you can see that these patients are still 5 years out from their diagnosis, experiencing significant effects from their cancer diagnosis and treatment. If you want to go on to the next slide, I just like this little graphic because it helps to illustrate how wellness is tying all of these components together. And you can go on to the next slide. Without stealing any thunder from Dr. Champ, whose talk is next, I did put up a slide of a trial that was done in 2019. You know, our goal is to continue to improve on these symptoms. And this is one of the first randomized trials in breast cancer survivors looking at an exercise intervention. Exercise is known to significantly improve many of the late and long-term effects of breast cancer. And I won't, in the interest of time, and because Dr. Champ's going to talk even more about this in detail, go through that in too much detail. But if you want to go on to the next slide, we have many collaborative programs at Duke that are trying to, in a multidisciplinary fashion, address these many disparate issues that breast cancer survivors have. We have the sexual health program for survivors of women's cancers. We have a phenomenal cancer patient support program that offers counseling and many other supportive services free of charge to our breast cancer patients. We have a cardio-oncology clinic, and currently within breast cancer clinic, we have added cardio-oncology presence. So cardiologists seeing patients in tandem with us to address the possible late cardiac side effects. We have a wonderful smoking cessation program, an oncofertility program, a beautiful Center for Integrative Medicine, and we are working on starting a multidisciplinary cancer treatment-induced neuropathy clinic. And these are just some of the ways that we are in a multidisciplinary and collaborative fashion trying to address these many survivorship needs. In
Dr.
summary,
Westbrook.
yeah.
Sorry to interrupt. I think we're going to have
Oh, that's okay. My summary slide is next.
move on. Perfect. Let me click through.
Thank you guys so much. I'm just sorry that you couldn't see me.
Thank you so much for that wonderful talk. Let me stop sharing, and then while we're getting ready, Dr. Champ can pull up his slides. Just a reminder, we can be answering some questions in the Q&A box while these presentations are ongoing. So if you've already presented, you can address some of those so folks can get their questions answered. The next presenter will be Dr. Colin Champ. He is a radiation oncologist here at Duke. He's an associate professor in the Department of Radiation Oncology, where he treats both breast cancer and lymphoma. His research is involving the impact of nutrition and exercise on both cancer prevention and outcomes. So I'll turn it over to you, Dr. Champ. Thank you.
Thanks, Dr. Rosenberger. Can you all see my screen with the slides?
Yes, we can. Thanks.
All right, great. So in 10 minutes, I'm gonna just scratch the surface of what we need to know about exercise before, during, and after breast cancer. This is a topic that's near and dear to me, and there is a lot of information online. So hopefully this sparks some enthusiasm. Okay. So I'll start out with some good and bad news for the first two slides. As you see here on the left, this is a study from actually one of our prior students showing in black here that the risk of death from cancer in breast cancer, women with breast cancer that are treated, is steadily decreasing. So this is a good thing. So we're getting much better at curing breast cancer. We have better treatments. We're getting better at finding it early on through better screening. So that's all good news. The bad news is when you see the green curve here, there's other issues that are increasing. And so while breast cancer specific cure rates are increasing and death is decreasing, we're dying from other things. And while that's expected to some degree, because we all have to go from something, it's just happening at an earlier age than we would like to see. And as you see on the right here, these are a bunch of different types of cancers, but the pink is breast cancer. And we'll just look at women age 45 to 49 that are treated for breast cancer have about a 15 times higher risk of having a diabetes related illness. So we're getting better at curing breast cancer. We just need to get better at stopping other diseases that are filling the gap. And the good and the bad is one way to help do this is to increase exercise, increase activity levels, as we know that it provides many non-cancer benefits, just general health benefits. And we'll talk in a minute about the cancer specific benefits that it provides. But this is a study that we did in breast cancer patients that were undergoing radiation therapy, 4 weeks of treatment. We put this activity tracker on them that was donated by the company nicely. And what we found, 4 things that we looked at step count in these women, and they were averaging about 5,000 steps per day prior to the radiation. Distance traveled, they were walking about 1.6 miles per day. They were burning about 1,800 calories per day, and they were sleeping 6.8 hours per night. That's kind of the bad news. That's not as much as we would like in all of those domains. The good news was during treatment, it really didn't decrease very much. The step count only decreased by about 54 steps per day. The distance was 0.02. That's negligible. The calories were negligible. So the good news is at least radiation therapy doesn't impact activity levels very much. The bad news is we need to get those activity levels higher before we even start any treatment, because we're not hitting the baselines where we should be. So my first takeaway, I'm really going to only have two takeaways in this talk. The first is move often and move a lot. And this is a study that was just published in the JNCI. Really the biggest study ever looking at this. This was 1,300 women who were treated for breast cancer and followed up afterwards. And what we found in these women was that at year 1, notice this is all negative, their risk of recurrence in women that exercised versus those that didn't dropped by 42%. So that is a cancer-specific outcome improved by exercise, and the risk of death was reduced by 55%. So those are impressive numbers. When they followed these women out year 2, so 2 years out after completion of their breast cancer treatment, the risk of recurrence decreased by 55% in those women that exercised versus those that didn't, and the risk of dying of anything decreased by 68%. So these are some profound numbers. So doing any kind of exercise, doing any kind of movement activity is good. But what they also found was when they looked at drops in mortality, women that exercised low, moderate, or high activity, the more active you were, the larger the decrease in your risk of dying was. It reached almost 70% in women that were very, very, very active. So it's not just being active, it's not just moving a lot. There's something about moving a lot, often, and intensely. And so I want to convince you in my last couple minutes here is that not all exercise is the same. And so if you came to me, or if you came to one of the exercise physiologists that I work with and said, I want to exercise, I want to do resistance training, I want to, let's say, work out my lower extremities or my quads, that can mean a lot of different things. So the woman on the left here in the fluorescent pink tank top, she's doing leg extensions. This activates your quad muscle in a very kind of non-impact type of fashion. So it's not very effective way of exercising. Whereas in the middle here, you have this woman doing goblet squats. She's doing some basic movement patterns. She's stressing her hips. She's stressing her lower extremities. She's stressing her upper extremities to hold that weight. And she's doing a squat. So that's much more intense activity. And then on the far right here, this is a whole different can of worms. This is the woman that I buy my raw butter off of, who wanted to get into weightlifting. And so she's really put a lot of effort in over the past couple of years. She's almost 70. She deadlifted this weight and then pressed it over her head. This is something that probably less than 1% of the population can actually do. They're all working out their quad muscles, but obviously you see from left to right, there's a significant different dose of radiation going on here. And so we'll come back to that in a second, but we know importantly that not only is exercise good for you, but body composition and survival after breast cancer treatment is very important. What body composition means is good body composition would be high amounts of muscle and low amounts of fat, and high amounts of good muscle. And when this group followed 3,000 women with stage 2 and 3 breast cancer after their treatment, they found that women with sarcopenia, that's on the far left here, sarcopenia means low amounts of muscle. Women without sarcopenia lived significantly longer than those women with low amounts of muscle. Women with radiodense muscles, so thick packed in muscles, did much better as well after treatment for their breast cancer. And then on the far right here, women with lower amounts of body fat lived significantly longer than women with higher amounts of body fat. So this is one of many studies telling us that body composition is key here. Not the scale, not your BMI, none of those things. It's the amount of muscle you have. You want to optimize that and you want to decrease the amount of fat you have. In terms of the amount of fat you have, there's really, the main way to do that is through diet. We're obviously not talking about that today. But there's only one way to increase muscle mass, and that's through exercise. There's really no other way. And so what's the best way to exercise? And I'm gonna answer that question in 3 minutes. This is based on the available literature. So in terms of body composition, lean muscle mass, or lean body mass, we think of bone density and we think of muscle mass. And when we think of bone strength and bone density, in the exercise world, we think of biomechanical strain on the bone. So there's only so many ways you can stress a bone. You can tense it, you can stretch it out, you could do compression, and that's the most common. So if you think about if you jump up in the air and land, your femur is going to be compressed. If you do a squat, As you see the woman here, the silhouette, if you do a squat, you're going to compress your femur as well. And that's going to cause some stresses on the bone. And there's shear stresses. So twisting, turning, those kind of things. And what happens is those stresses actually cause parts of the bones that look like Swiss cheese to collapse on themselves. And when that happens, it sends out hormonal signals that migrate these cells called osteoblasts. They go to that area and then they lay down more collagen and structural proteins. So actually heavy lifting, tensing our and stressing our bones actually causes them to grow back stronger. So much like when you're lifting to increase muscle mass, the same exact mechanisms will increase bone mineral density. And this is why we know that in both premenopausal and postmenopausal women, premenopausal are the empty blocks and the postmenopausal are the dark blocks. If we look at on the left here, their forearms, and we look at on the right, their femoral bones and their lower extremities. As women are stronger, their bone mineral density goes up. And this makes sense, right? That means these women are stressing their bones much more often because they're stronger, they're lifting heavier weights, etc. So the first thing we need to keep in mind is we need to stress our bones enough during exercise that it causes that migration of these cells to cause the bones to grow back stronger. You have to hit a certain amount to do that. It's actually 10% of the force required to cause a fracture, to break your bone. 10% of that force is required to cause increased bone mineral density. That's going to help offset some of the side effects of cancer treatment. Hypertrophy or muscle growth is the same phenomena. So on the left here, we have this woman squatting again. What's happening during the squat is this muscle, this sarcomere is stretched out. It comes back together. It compresses back together to cause a contraction of the muscle. And depending on how hard that contraction is, you're going to get damage to the muscle. And much like when you damage the bone, it's going to grow back stronger. It's going to grow back thicker. It's going to grow back more dense. And on the right here, it's the same phenomena. So force production is on the x-axis here. The amount of muscles that are recruited is on the y-axis, and you see it go up linearly. So as you lift heavier weights, as you stress yourself, as you strain these muscles, as you do more powerful movements, you're going to recruit more muscles. You're going to cause damage to more of those muscles, and they're going to grow back bigger and stronger. But again, you have to hit this threshold. These are 6 to 10 repetitions. These are 1 to 5 repetitions. So these are, by 10 repetitions, you can't even lift anymore. It's that difficult. That's what it takes to cause damage to the muscle and have them grow back stronger. And these are the dose that we prescribe our breast cancer patients when they're exercising after treatment. And the way we view this is through 5 normal body movements. There's push, there's pull, there's hinge, there's a squat and lunge, which is what the last woman was doing, and then there's a core and carry. And the problem on our end as physicians is we had one of our students go back and look through every study doing resistance training in women with breast cancer. And this is a busy slide, but only in purple, when the purple line reaches here, did the studies do adequate dosage of exercise to induce hypertrophy, to increase muscle hypertrophy. Most studies were just not diagnosed, or were just not prescribing a high enough dose of exercise to do that. It has to be difficult. It has to be per muscle group, 5 to 10 exercises per week with 10 repetitions. And we're not doing that with a lot of these studies. The other benefit of increasing muscle mass and hypertrophy, and this study actually was just published in Science, the lead author is here at Duke. But if we look on the top left here, if we look in older adults, if we look in kids, if we look in neonates, on the top right here, if we look in men and we look in women, and then on the bottom here, same thing, kids, women, adults, children, etc. Resting metabolic rate, so the amount of metabolism, the amount of fuel we burn just sitting at rest, the amount of calories we will burn just sitting at rest is always directly proportional to our muscle mass and our fat-free mass. So all those things that we're trying to improve from exercise, that will increase our metabolism. So we will have less weight. We will have less adipose tissue on us. We'll have all these other health benefits, but the only way to increase muscle mass is through exercise. And that's through exercises that can increase hypertrophy. The only other way to increase Fat-free mass is through bone density, and the only way to increase that again is through exercises that will stimulate bone growth. And so I want to give you two takeaways here. The first is to move often. There's a plethora of studies showing that women treated for breast cancer do better with their outcomes, both specifically to breast cancer and also their just general health, if they move a lot and move often. And then the last one is we have to exercise intensely. We have to lift heavier weights. We have to lift weights that by the 10th rep, they're actually quite difficult, so that we can hit that dose to stimulate both bone and muscle growth, because if we don't, we will not get those benefits. I'm not saying that that type of exercise isn't good for you, because it is, but if we want to improve our muscle mass, if we want to improve our bone mineral density, we need to hit that dose enough that's high enough to stimulate that growth. And this is a picture of our 22-month-old who with perfect form is deadlifting, because she knows that it has to be heavy enough to stimulate her bone growth and muscle hypertrophy. So I hope this is helpful, and I hope this stimulates some thought process. And please go online or contact me with any other questions about this. So thank you.
Thank you so much, Dr. Champ. That was fantastic. And I think you have inspired us all to get out there today and increase those steps in that activity.
Good.
So the next session will be two folks together. So I'll introduce them together, and then we'll have you sort of pass the mic from one to the other. So our first presenter will be LaSonia Barnett. She is a senior program coordinator and certified patient navigator, and she works here in the Duke Cancer Institute's Office for Health Equity. In her role, she's fully responsible for all activities within the community outreach and engagement programs, health education, health screening, and the community-facing navigation programs. Her counterpart is Nadia Aguilera Funes, who has degrees in psychology and Spanish, a native to Honduras but raised here in Durham, is a certified patient navigator and health educator at the Duke Cancer Institute's Office of Health Equity also. And her goal really is to continue to strengthen the bridge between historically marginalized communities and the healthcare system to decrease health disparities. So thank you both for joining us today, and I will turn over the mic.
Thank you so much, Dr. Rosenberger. Thank you everybody for being here with us on a Saturday, and for just giving us your time and attention. So as Dr. Rosenberger mentioned, my name is Nadia Aguilera, and I'm going to allow my supervisor, LaSonia Barnett, to introduce herself first, and then I will begin our presentation.
And Nadia, can you bring up the slides for me, please?
Sure. So I'll go ahead and let you
Okay.
introduce yourself while I bring them up.
All right, I appreciate it. Good morning, everyone. I'm LaSonia Barnett, and I'm the Senior Program Coordinator for the Office of Health Equity at the Duke Cancer Institute. And I am so glad to be here this morning to talk about resources and access to care.
All right, I'm gonna share my screen. Let me know if you can see it, Sonia.
We can see it? Mm-hmm.
All right, is it full screen?
That looks great. Yep.
It looks great.
Wonderful. Thank you so much. So we are so excited to be a part of What's Best for Breast. We were a part of it last year, and we've been really excited throughout the whole planning process. And this is definitely a conversation with clinicians and other support services. So we have put together a presentation for you to talk about resources and access to care. LaSonia has introduced herself, and I was introduced. We are both patient navigators, certified patient navigators at the Duke Office of Health Equity under the Duke Cancer Institute. So to start off, we want to talk about cancer and COVID. We know COVID has impacted us worldwide, and with breast cancer awareness, I have this quote here from the from the NIH, which you can find in cancer.gov, but delays in screening, the experts warned, could mean that the missed cancers might be larger and more advanced when they were ultimately detected. In general, cancers are easier to treat in their earlier stages. So we really just wanted to highlight the importance of going back to your screenings, despite the fact that they may have been canceled due to COVID. We, as patient navigators, have experienced lots of folks in the community who have lost their jobs and at the same time lost their health insurance. And that is the main reason why they are not continuing with their cancer screenings. We want you to know that delaying your screening can delay diagnosis and lead to, to you finding worse outcomes. So we want you to, if you did cancel that appointment due to COVID because you lost your job or whatever the reason may be, reschedule. And so that's what patient navigation is all about. Before the pandemic, we were seeing people who were going through similar circumstances of losing their job or not having adequate or insurance at all. And so we want to let you know that patient navigation is here to help with that. And as was mentioned before, that is our purpose, is to be that bridge between the community and health systems to get people to care. And so my next slide this is our, like, the root of our message for the community. It's that primary care is probably the most important, or the root of where health, a healthy life and healthy lifestyle and just health in general begins. And so I want to mention that I was very excited to see Dr. Baltaro on here talking about primary care, because I really think that is probably the most important doctor that any person will have, is that one provider or group of providers who manage the care and do the appropriate referrals. And also, I just wanted to thank Dr. Tomey for lifting up health disparities, because this is something that was an issue even before the pandemic. So I wanted to just really quickly let you know what patient navigation is. So patient navigation was started by Dr. Harold Freeman. He's an African-American breast surgeon in Manhattan, New York, who began patient navigation. He began this by doing something about the red flags. And so I want to encourage all providers that are here to think about this and how he made a difference by beginning patient navigation. And the red flag for him was that all minority women that were showing up in his office were showing up with later stages of cancer. And so he did something about it, and he started a patient navigation. And patient navigators, what we do is we walk with patients and we connect them to resources to help them overcome all barriers to access adequate healthcare, specifically for cancer education, prevention, screening, treatment, and survivorship. And we have two different types of navigation here at Duke. We have the community-facing navigation, which is what Lasagna and I do. And then we have the inpatient navigation, which is what usually nurse navigators will do inside the cancer center. So here I just have this slide letting you know about primary care. As I mentioned, they manage your care and do the appropriate referrals. And I wanted to mention also for everybody that's here listening that primary care is not common knowledge for everyone in the community. There's a lot of people that are not aware about the importance of it, or there's a lot of people who migrate to the States who don't know the health system and don't know that primary care is even something that exists or that they can take advantage of. Oh, and to go back really quick, sorry. These are some of the things that these primary care providers can refer to: specialty care, diagnostic testing, financial counseling, social workers, navigators, and interpreting services, which are all very important support services. And so as patient navigators, we focus on connecting community members who don't have insurance to federally qualified health centers. And so we have this information here, and I encourage everyone to take out your pen and paper or come back to the recording to write down all of these phone numbers. And if you yourself, a family member, or someone in your community does not have a primary care provider, please help them get connected to a federally qualified health center. These centers operate on a sliding scale, so you don't have to have insurance, and usually they do it according to your income, so people can have a primary care doctor. So whether you have insurance or not, every human being in the United States should have a primary care provider. And we, as mentioned here at the bottom, that is one of the primary things that we do at the Office of Health Equity, is connect community to the appropriate health center. So really quick, this is another resource you can write down. You can find your local health department where they usually have clinics as well. And we included the website and the phone number. There's also free clinics that you can find, which are other places where you can establish your primary care. I'm going to turn it over to Lasagna now.
Thank you so much, Nadia. So I want to talk a little bit about the breast and cervical cancer control program. So this is another resource for individuals that are underinsured or uninsured. The eligibility for the BCEP program, you must be without Medicare Part B or Medicaid, between the ages of 40 to 64 for breast screening services, and between the ages of 21 to 64 for cervical screening services. And you must have a household income at or below 250% of the federal poverty level. Next slide. So some of the services that the Breast and Cervical Cancer Control Program provide are the cervical cancer screenings, which can include Pap test, HPV test, clinical breast exams, screening breast exams, screening mammograms. They also provide diagnostic procedures that indicate diagnostic mammograms, ultrasounds, colposcopies, breast and cervical biopsies, as well as medical consultations. So Breast and Cervical Cancer Medicaid provides funding for treatment to women who are diagnosed with breast or cervical cancer and who meet the North Carolina Breast and Cervical Cancer Control Program eligibility requirements, as I stated in the previous slide. So here is the contact information for the BCEP program. You have the phone number as well as the website. Next slide. So here is a map that we use as navigators within our office to determine where are the breast and cervical cancer control programs across North Carolina. So since we work for the Duke Cancer Institute, which is the NCI designated cancer institute or cancer center, it's important for us to be able to know where the breast and cervical and cancer control programs are located across North Carolina, because we're mandated to work across North Carolina to navigate patients to services. And this map shows you where you have the breast and cervical cancer control programs. And you also see a heart on the map. And this is also the North Carolina Wise Woman Project that I will talk about in the next slide, that also can go in conjunction with the BCEP program as well for women. And if you notice that you do not have so many hearts on the map as opposed to the BCEP program, so you don't always have the BCEP and Wise Woman program that come together within the same area. Sometimes you do not have that Wise Woman program in those areas. Next slide. So the North Carolina Wise Woman program, like I said, can be used in conjunction with the Breast and Cervical Cancer Control Program for women ages 40 to 64. assistance for low income, underinsured, uninsured, and to improve physical health as it relates to cardiovascular and other chronic diseases. And here you have the contact information for the North Carolina Wise Woman Program. Project Access. Now, this is an initiative that provides access to specialty care. If you notice that Nadia spoke about the different specialty care on the slides prior to this, such as oncology or any orthopedic services. So for individuals that are uninsured and they need to have specialty care, here's a program that they may be eligible for. So Durham residents can be referred to the Lincoln Community Health Center for Project Access. And here we have the appointment line number located on the slide. And then you have Wake County that also provides Project Access services for eligible individuals. And you have the contact number here. I want to mention that also there is another program called Pretty in Pink. They provide treatment, financial assistance for North Carolina breast cancer, underinsured and uninsured patients. And here's the contact information. Next slide. So the American Cancer Society also provides a lot of support services on their website, and we have the website link located here as well as the phone number. Some of the resources that they provide is the understanding of your different diagnoses, and it's not just breast cancer, but other cancers as well. You're able to find and look for ways to pay for your treatment. Treatments of side effects, it provides survivorship services during and after treatment. They provide services for caregivers and families, as well as children and cancer, end of life information. So this is a great resource. If you do not know where to turn, if you have a family member that has been diagnosed with cancer, the American Cancer Society can provide you with so many resources. So this is a great resource to keep in your arsenal. The Centers for Disease Control and Prevention, on their website, they provide also a lot of information to national programs, data and statistics, risk factors about cancer and kinds of cancer. They also talk about COVID and cancer as well, and ways of preventing cancer. And they do have a resource library, which is very useful to individuals that are looking for more information in regards to cancer. And we have listed the contact information on the slide. Next slide.
Sonia, I'll have you just wrap up.
Sure. As Nadia mentioned, we are community-facing navigators, and what you will receive after this presentation is over, you will receive some information about our navigation services in English and Spanish, as well as a listing of federal qualified healthcare centers across North Carolina. So you'll be able to reach back out to us if necessary. Thank you.
Thank you so much, LaSonia and Nadia. I really appreciate it. This is a really important topic. And I think one that we often are wondering, where do we get these resources, what exists, and which ones match for each individual patient. So thank you for everything you do.
Thank you for having us.
We'll move along. The last speaker of this session will be Dr. Robin Batchelder. She is an associate professor of surgery and pathology, and she leads a translational breast cancer research lab. She's been at Duke for 16 years, and she specializes in studies of triple negative breast cancer with chemotherapy resistance and breast fat as a contributor to breast cancer risk and progression. So she will be speaking today about breast cancer research, and I will turn it over to her.
Thank you, Dr. Rosenberg, and thank you everyone for inviting me to speak here. I've never had the opportunity before, so this is going to be a switch of gears for everyone. I'm a researcher in breast cancer, as Dr. Rosenberger pointed out. I've been at Duke for 16 years. I'm fascinated with triple negative breast cancer because of the lack of effective therapies. So a lot of my research focuses on triple negative. But one of the things that I've started studying with a reconstructive surgeon in the past couple of years is the contribution of breast fat to breast cancer risk and progression. So that's what I'm going to talk to you about today. Bear with me. Can everyone see my slides?
Yes, thank you.
So I think everyone in this audience knows that, tumors are not just composed of tumor cells. In this slide, it's shown as the tumor cells are shown kind of in pastel color circles, but there's a lot of host cells that really influence cancer risk and progression. And the most popular are the immune cells. We know our immune cells facilitate breast cancer progression, as well as blood vessels. But one thing that has been overlooked in terms of breast cancer is the fact that breast fat really is the central component of the breast. It takes up a huge amount of volume. And to date, it really isn't known if this fat tissue, which is so abundant, if it can actually drive breast cancer risk or promote breast cancer progression. So I'm particularly interested in this because adipose tissue is an organ that actually secretes many inflammatory factors. And when we think about inflammatory factors, it doesn't matter what they are. We think about disease, and we know that cancers are very inflammatory environments. So I think thinking about breast tissue in the context of breast cancer is important, and that's what our lab is. So for the past 2 years, I've joined a team with Dr. Hollenbeck. Dr. Hollenbeck is a reconstructive surgeon at Duke, and he does reconstruction on women that have breast cancer and need a mastectomy. So what we've been doing is to build a breast fat cell repository from women that are at high risk for developing breast cancer. So these types of women are people with BRCA mutations, other genetic mutations that would be predisposing to breast cancer, as well as breast cancer patients themselves. So we have this repository of fat cells in the lab that we study to look at their biology and whether it might be abnormal. So this is a picture of the cells that we grow in the lab for a very brief amount of time to make sure that they still resemble the original adipose tissue. So this is a picture of that, what we call adipose stromal cells that we grow in the lab. So a theme that has come to our attention in these studies is that a lot of high-risk women have fat cells that are senescent. And senescent is just a big word for a cell that, due to stress and damage, actually becomes growth arrested and, most importantly, secretes a lot of inflammatory factors. You might have heard about senescence in the context of aging. So senescence is really the reason we age. Our cells deteriorate because of this senescent biology. So I'm just going to show you a little bit of the primary data from our lab. This is looking at fat cells from a BRCA mutant patient and from a BRCA wild type patient. And this is held up to be true for all patients that have BRCA mutations. What we see is that their adipose or fat cells stain blue for a senescence marker, whereas the wild type patients do not. So senescence is really associated with the fat cells in these patients. And also when we look at inflammatory factors or cytokines that are secreted by these cells, we see that the BRCA mutant patients have fat cells that secrete much more of these inflammatory factors. It doesn't matter what they are. One of the factors that we study is interleukin-6. So the other risk factor that we've studied is obesity, and we have heard a lot about that in today's sessions. We are isolating fat cells from obese women as well as women with metabolic disease. And what we found is that obesity seems to drive senescence. So these are fat cells, breast fat cells that we've isolated from a woman with a BMI of 26 and a woman of a BMI of 38. And this is just an example to show how positive these cells are for the senescence or inflammatory marker. Also, these cells what we do is we take the cells in vitro and we study what they secrete into the media that they're growing in. And this is looking at inflammatory factors in that media. So here's interleukin-6. And what we've seen is that in the low BMI women, the levels of this inflammatory factor are much lower than in the high BMI women. And similarly for another inflammatory cytokine, interleukin 8, you see the BMI 38 patient, fat cells secreted much more IL-8 than did the BMI 26 patient fat cells. Okay, so that's a glimpse of some of the types of data we're generating, showing that breast fat cells from some women who are at high risk for breast cancer demonstrate aberrant biologies. And this biology is a senescent, growth-arrested inflammatory cell type. So you may ask, well, why is that important? And it's our feeling that the identification of this defective signaling in breast fat, number one, it'll demonstrate that breast fat tissue is an important component of the breast tumor microenvironment. We need to study how it interacts with other breast cells to drive breast cancer risk and progression. But also, we're very interested in identifying fat-specific pathways that we might be able to target to reduce breast cancer risk and progression. And in this way, we might be able to avoid mastectomies, which of course have a lot of side effects for women that they don't want to go through. So wouldn't it be nice to generate some kind of therapy that we could treat high-risk women with to reduce their breast cancer risk? Okay, so finally, I just wanted to show a cartoon of what I just said in words in my last slide. So our lab's hypothesis, overarching hypothesis, is that inflammatory breast fat tissue is a breast cancer risk factor. So this fat tissue, here we're showing a fat cell from an obese patient, and I've told you that those cells are senescent. They secrete inflammatory cytokines. And what we're testing in the lab currently is whether these inflammatory cytokines that are secreted can act on other cells in the breast, the structural cells of the breast, the epithelial cells, to actually promote events that drive breast cancer. And then just to bring this full circle, our ultimate goal is to use these pathways to think about what would be a logical therapy to actually reduce this incidence by targeting the fat. So for example, we're very interested in an FDA-approved IL-6 receptor neutralizing antibody that's made by Roche. It is called tocilizumab, and it is used for the treatment of rheumatoid arthritis. But could we repurpose this drug to actually reduce a woman's breast cancer risk? It's an area of interest. Okay, and just a few other, before I end, just a couple of other things we're interested in. We do have data to suggest that metabolic disorder, which we've heard a lot about today, is also driving this inflammatory fat tissue biology. Senescence, like I mentioned earlier, is also associated with aging. So as we age, do our fat cells increase their senescent inflammatory biology, and is this driving breast cancer? And finally, one thing that I'm very interested in is race and whether there may be racial determinants that drive senescence in fat tissue. Okay, so just a quick acknowledgement slide. As I mentioned, my colleague, Dr. Hollenbeck, reconstructive surgeon, we co-lead what we call a Dippo oncology laboratory at Duke Surgery. Valerie Nelson, a very talented lab manager, has been central to these studies, as well as 3 medical students that are training in the lab that have had a huge role in generating the type of data I showed you today. And finally, I have to acknowledge Dr. Shelley Wong and Dr. Jeffrey Marks. That we share lab space, we share interests in factors that drive progression of cancer, and they've been great colleagues intellectually and support-wise. So I'd be happy to answer any questions you have.
Thank you so very much, Dr. Batchelder. That's a really great talk. And it's really incredible how many really talented scientists are doing research in this space, and look forward to making more connections with you. We are already at the top of the hour, so I will just point everyone's attention back to the Q&A forum, where lots of fabulous questions have been asked and answered. So things on oncofertility and tattoos and exercise and what's right. So we'll point people back there, and I will turn the platform back to Dr. Plickta. Thank you.
Excellent. Special thank you to all of the panelists today, the moderators, the speakers, fantastic presentation. So proud to be a part of this event. A shout out to all of the attendees today. We greatly appreciate your support of today's event. And just want to share a couple things here as we close out the formal event and lead into our more information panel. So again, thank you to everyone for participating today. Greatly appreciate your support. One final thank you to our presenting sponsor, Invitae Genetics. A thanks again to our planning committee, without whom today's event would not be possible. Again, consider joining us for Making Strides, the American Cancer Society event later this month on October 23rd. Remember that you will get a survey after today's event. I think when you close the webinar, actually, you'll be prompted to consider filling out our survey. You'll also receive an email with a link to the survey. So please, I've had a few suggestions about topics you'd like to have in the future. Please include those in the survey so that our planning committee for next year will give those full consideration. Don't forget, you can continue to get updates on our website, breasthealth.duke.edu. And now that concludes our formal What's Best for Breast event, but we are going to stay online for about another 30 minutes or so and continue to answer any questions that you might have. We are going to continue to use the Q&A to address those questions, so please do put those in there and we will get to them as quickly as we can. We do have a few additional presenters that would like to share a little bit of information with you. So if you have time to continue to join with us, we would certainly appreciate your participation. But for those that need to go, we totally understand. And so I would like to now take the time to introduce the people that are going to be on this final extra panel. It's like a bonus panel, let's say. And starting us off is going to be Invitae Genetics. So I'm going to stop sharing. And I believe Ms. O'Neill is with us today to give us a little information about Invitae.
Hello, everybody. I have to say that this has been an absolutely fantastic program today, and we are so honored to be able to sponsor this for all of you. But to not have to listen to me talk, I actually just have a really quick video that shows what Invitae is doing in the genetic space. So let me pull that up for you. Can you all hear this?
Genetic testing really used to be tailored to a very niche group of people. We were looking for red flags in the family and personal history. We were looking for, young individuals. And it's slowly expanding into being really important for the general population.
We're all becoming more and more aware every day of how important genetics is, not just to the people who have something running in their family, and not just to people who have cancer or some other condition, but to everybody. Genetics is involved in everybody's lives and can impact everyone's health to one degree or another.
We're reaching a lot more people than we used to. Just the impact that we can have on one life is pretty astounding. If we do, and I expect that we will, achieve our mission of reaching billions of people, I can't even calculate what that would do.
Genetic testing previously has been really limited to those people who have good insurance coverage or can afford to pay for the testing, and Invitae believes that's not right.
The sky's the limit in terms of what Invitae can contribute to the medical science, to the clinical care of patients, and to our overall understanding of what role genetics has to play in everyone's lives at all different stages of life. Hard to predict exactly where we'll be in 5 years, but I imagine it'll be only bigger and better than where we are right now.
And with that, if you have any questions, please direct them to your physicians and the clinical cancer genetic team over at Duke University.
Excellent. Thank you so much for joining us today, and again for Invitae's support of our event. Next, I'd like to turn it over to the Duke Cancer Institute's Office of Health Equity. We already heard from some of these lovely women today, but I'll give them a chance to reintroduce themselves.
Thank you, Dr. Plickta. So are we starting our 2 to 3 minutes? Is this what's next?
That's
okay.
what that is. Yep.
Wonderful. So let me share my screen. I can find her. And Sonia, if you can let me know if you
can see it.
So I'm trying to pull up the here we go. Can you see the
We can.
pager?
Looks good.
Okay. Sounds good. So really quickly, thank you so much for staying with us. This is something that we will be providing to you after the event. And so we just want to let you know about our services. We do patient navigation. Patient navigation is for everyone, whether you have insurance or don't have insurance. We provide a wide variety of services, but we look at a person holistically. And we also do a lot of assessment around social determinants of health. We know that health, everything is connected to health. So we really look at everything and every barrier that patients encounter, and we help them overcome these by providing the right resources or doing the right referrals to places that we trust. So you'll have a chance to go through this. At the very bottom, you'll see our information as well, Lasagna and I's email. You can also reach the phone number here, which is the phone number for our office. And we're so excited to be able to help. This is the one flyer that we think is extremely important for our community, provided by the American Cancer Society. This goes over the different ages when providers recommend cancer screening tests to be done. And then if you look at, if you look at each one, you will see, like, for women, for men, and which tests are required. We always want you to remember that connecting to a primary care is the most important thing. If you don't have one, or if for some reason you don't have a good relationship with yours and want to change and want to look for other options, we can help you do that. Also remembering that you can contact our office at any time. I'm sorry, and then I'm going to let Lasagna go over a quick testimony from our office, just so that you can get a visual of what we do as patient navigators.
Thank you so much, Nadia. I am a firm believer in a story is worth 1,000 words. So I just want to talk about the navigation process through a testimony of one of the individuals that we have worked with in the past. We had a 60-year-old African-American female that was referred to us by our radiology navigators, which are able to refer individuals that may have a suspicious finding. And this particular patient was coming through the ER and had a suspicious finding in their breast, and the patient was referred to us. At the time, the patient was worried about receiving her COVID medications because she could not afford them. So that was the first thing that we dealt with this particular individual. And so we were able to help her get her medications based on her income. The medications were free. And so as I asked more questions of the patient, I asked her, how long had it been since she had a mammogram? 2 to 3 years. She hadn't had one in a moment. And neither did she have a colonoscopy. Remember, I'm saying she's 60 years of age. So, I continued to make sure that we were able to connect her to get a mammogram because that was very important. All she was really concerned was her COVID diagnosis. She said, okay, I'll get my mammogram, but it's probably nothing. So she gets a mammogram and we find out that she has stage 1 breast cancer. And it floored me. But this is the things that we do in our office. And she went through treatment and she was able to catch it at an early stage. And so it's important that we make sure we connect the individuals to care. She had many barriers. She lost her job, her insurance. She was going to lose her housing as well. So these are some of the things that we do within the office to make sure that we connect individuals within the community to resources to make sure that they receive their screenings. So, this is just a story to kind of give you an idea of what we provide or the service that we provide in our office. So please, when you receive that flyer, don't hesitate to reach out to us because that's what we're here for. We want to help. We want to hear from you. Thank you.
Thank you so much. Next, I'd like to introduce Survivor Friendly. Are you with us?
Hi, yes, we are here.
Great.
Hi, so I'm Stacey and I'm coming to you from Survivor Friendly, and we're excited to tell you a little bit about what we have to offer. So we are a certified DME facility that specializes in mastectomy products and services for breast cancer patients. We currently have 3 locations, with our main office being here in Cary, and we specialize in breast prosthesis, mastectomy bras, and compression garments. We have well-trained certified fitters on staff to properly fit and measure patients for these garments. For breast prosthesis, we offer a variety of off-the-shelf, including silicone forms, shapers, leisure forms, and swim forms. And we offer custom breast prosthesis, which many patients are not aware of. This is where we use technology to scan a patient's body to create a prosthesis that fits her, matches her skin color, and looks like her. This is a great option for those that are not eligible to get reconstructive surgery. For mastectomy bras, this is an important garment for a patient, as it can impact not only her recovery process, but can impact her posture, balance, and symmetry kind of throughout the rest of her life. So it's important that she gets a proper fitting garment. We have a variety of mastectomy bras, anywhere from post-surgery and beyond, including activewear. We have everyday comfort bras, beautiful feminine bras, and so on. And these bras are covered by patients' insurance on a yearly basis. Many patients also develop lymphedema during this time. So it's important that they have compression garments that reduce the swelling caused by lymphedema. We do offer off-the-shelf as well as custom compression garments made from the best vendors that we can find, just so they ensure they get top quality garments. One of our goals is to ensure that patients come to us at the beginning of our consultation, so that we can ensure that they get the proper information that they need beyond their surgery, so that they can have a smoother transition back into life. Another thing is that most of our items are covered by insurance, which we do file on your behalf. We do Medicare, Medicaid, and most private insurances. If you do not have insurance, that is okay. We will make sure that we have the resources to make sure that you get the garments that you need. And just to kind of wrap it up, we offer other services as well, including wigs. We do all natural skincare and nail care products to help that are safe for those that are going through chemo and radiation. And we also have a boutique full of beautiful jewelry, accessories, and any other thing to create a one-stop shop for those patients to be able to feel good about themselves. So thank you so much, and we look forward to any questions that you may have.
Thank you for joining us, Jackie. And can you remind us one more time, where are you located?
We are located in Survivor Friendly in Cary, North Carolina.
In Cary, excellent. Thank you so much. Next, I'd like to introduce the Duke Breast Surgery team, represented by our fellow. Dr. Miller, are you with us? There she is.
Hi, everyone. I'm Dr. Miller. I'm very, very happy to be a part of this amazing community event. Thank you very much for having me as one of the panelists. I'm currently, as Dr. Plickta just said, the Oncologic Breast Surgery Fellow here at Duke University, which means I am a general surgeon who will be specializing particularly in breast surgery when I complete my training next year. So I'm here as a panelist to be a part to answer questions that you may have. Obviously, I'm familiar with breast disorders, both cancerous and non-cancerous, and be happy to be a part and answer any questions that you may have. Thank you for having me.
Excellent. Thank you so much. And now I'd like to introduce the North Carolina Breast and Cervical Cancer Control Program, which was mentioned earlier by our Office of Health Equity, but today is being represented by Ms. Wright. Ms. Wright, are you with us?
Can you hear me, Dr. Plickta?
Yeah, if you could just speak up just a little bit more, please.
Great. Sure, yes, ma'am, we'll do that. So I'm joined with my fellow nurse consultant, Cindy Herndon and Angie Moody, and we have Miss Alanya Caesar on with us as well, who is a local BCEP navigator. Want to give a shout out to Sonia and Nadia for the excellent overview of our program. So we are the North Carolina Breast and Cervical Cancer Control Program. And it was a program that began as a program to address disparity, provide breast and cervical cancer screening for those women who didn't or don't have access to insurance or who are underinsured. So we're just so thankful for the opportunity to be a part of this wonderful morning. Thank you for all the providers and the excellent information that you've shared.
Excellent. Thank you so much. And now I'd like to introduce an organization that I'm particularly fond of because I send them a lot of patients their way, and that is FORCE, Facing Hereditary Cancer. And I believe we have Dr. Whalens joining us today.
Hi, yes, thank you so much. I'm going to share my screen for just a few slides to give you guys a picture of what FORCE is and what we can provide you in the area. So yeah, FORCE stands for Facing Our Risk of Cancer Empowered, and we are a national nonprofit that was founded in 1999, devoted to improving lives of individuals and families facing hereditary breast, ovarian, pancreatic, prostate, colorectal, and endometrial cancers. Our community includes people with a BRCA, ATM, PALB2, CHEK2, PTEN, or other inherited gene mutation, and those diagnosed with Lynch syndrome. We accomplish this through our education, support, advocacy, and research efforts. We are dedicated to providing up-to-date, expert-reviewed information and resources that help people make informed medical decisions. Our strong, supportive community of peers and professionals ensures that no one must face hereditary cancer alone. And FORCE serves as a champion, unifying the community and advocating for awareness, access to care, and better treatment and prevention options. And so, you know, why am I here today? Well, I'm a previvor with the BRCA1 genetic mutation. We first learned of this mutation after my mom was tested during her treatment for metastatic triple-negative breast cancer. Unfortunately, my mom passed from her disease in December of 2006, only 4 short months after being diagnosed. But her courage to get tested for BRCA mutations definitely has saved my life and the life of many of my family members. I was tested for the mutation in 2014 at Duke, and after I learned of my results, I was able to pull together a team of clinicians who are dedicated to my screening and surgical decisions. I recently had my preventative double mastectomy in August 2020, and my doctors were Dr. Plickta and Dr. Hollenbeck. I'm currently undergoing ovarian cancer screening with Dr. Haley Moss, and it hasn't been an easy road, but finding FORCE and the community that comes with FORCE has been life-changing for me. So finally, I just wanted to give you some more information about our local resources. I, along with Haley Blum, are 2 of the outreach leaders for FORCE in the Triangle area. We host monthly virtual support groups where we often have physicians in the local area come and answer any questions, including Dr. Plickta, who has come recently. On October 21st, we have our next meeting, which you can RSVP via email, noted there. And we'll be having Dr. Haley Moss, who I already mentioned, who's a gynecological oncologists that do come and answer questions. As well, we have lightly used surgery recovery supplies if those are needed, because I know they're expensive. So please reach out to me if you need those. Thank you.
Excellent. Thank you so much for joining us today. Always good to see you. And last but not least, we have the Duke Cancer Institute's oncology dietitian, Ms. Fisher-Streno, who's actually, I believe, joined us every year for What's Best for Breast, or at least it seems like she's been there since the beginning. So appreciate you being here today. Go ahead, take it away.
Oh, good afternoon, everybody. My name is Paige, and I am one of the oncology dietitians with DCI. I work primarily at Duke Women's Cancer Care in Raleigh and the Duke Cancer Centers in Cary. And our other Wake County clinics. I am here as a resource for during, before, and after treatment and survivorship. I like to tell everybody I'm like a shaman through the internet to help guide you to good resources versus resources that aren't so appropriate and helpful. So I'm here as a resource, and I'm excited to answer any questions that you have this afternoon. Thank you.
Thanks. Thanks so much, Paige. So good to have you with us again today. Normally, Paige is kind enough to do cooking demonstrations during What's Best for Breast Live, and so I kind of miss tasting whatever it is creation she's made. But I'm sure hopefully next year we'll be back in person and she'll be joining us for that event. But with that, that is everybody on this particular panel. So please, all the participants that have hung out with us for this long, continue to bring us questions into the Q&A. We do have people with us on the panel that are answering your questions. And while that's going on, maybe we will just address some of these that have already come in. So there was a comment here. Sounds like somebody on the attendee list has been a part of FORCE in the past. And is giving a shout out to Andrea and Haley, saying that they are indeed wonderful. We had a question about Oncotype scores that I believe Dr. Westbrook was able to answer. But Dr. Westbrook, do you maybe want to just take a second, if you can hear me, and expand on what is an Oncotype score and what do we do with that information?
Sure. And it seems like my video is still
That's okay.
not
We can hear you
working,
though.
so I'm really
Yeah.
sorry that you can't see me.
That's okay.
An oncotype is a genomic assay that is designed to predict recurrence. Okay, okay, good. So an oncotype is a genomic assay that's designed to predict really what it's just
Oh, Dr. Westbrook, I think we're losing you.
Is to predict responsiveness to chemotherapy. And can you hear me now?
Yeah, you're
Can you hear me
coming back
now?
in. Yep.
Okay.
Yep.
Okay. So I was just saying that an oncotype is designed for early stage hormone receptor positive. So that's ER and or PR positive, HER2 negative breast cancer. And it's designed to predict the sensitivity to chemotherapy. So we use it as a chemotherapy decision-making tool, but it also is prognostic in that it comes with a lot of data to represent how patients will do over the next 5 to 10 years, both with and without chemotherapy. All of the data from Oncotype does assume that people have been treated with endocrine therapy because these are all hormone-driven cancers. So it does come along with a percentage risk of recurrence over the next 9 to 10 years. We do try to extrapolate from that data what might happen if you stop your endocrine therapy, although we do recommend that people do as much as they can to stay on that. Oncotype is not approved for HER2 positive or triple negative breast cancers. It is really for risk assessment in the early stage hormone receptor positive cancers. Happy to take other specific questions about that or.
Yeah, I think that was great. Thank you so much. So the next question I'm going to hand back over to Paige. There was a question in the Q&A that says there's so many articles on the internet about diet and supplements after cancer. Where can I find correct information? You're muted.
That is such an awesome question. Thank you for sending that, whoever sent it. So I'm going to share my screen. Or maybe I'm not. But a great resource for everyone to go to would be the American Institute of Cancer Research. They work in concert with the World Cancer Research Fund, and their research is primarily on nutrition, physical activity for prevention and survivorship and preventing recurrence in cancer. They have dietitians on staff, and they are constantly updating their information. They have these continuous update reports. There's one specifically for premenopausal and one specifically for postmenopausal breast cancer and risks. But they like to emphasize the same thing I like to emphasize, is that if you can get nutrients through food, get it through food first. So supplementation is something that's very specific to each person. Usually for cancer survivors, especially breast cancer, we like to say, make sure that you have your vitamin D checked yearly, make sure you're taking in adequate amounts of calcium. So that would be something to discuss with your primary care provider or your oncology team. But other than that, it's really not beneficial to take individualized supplements, especially very large amounts of supplements. But if you can, our body's going to better utilize it through food, so try to do that first. A great diet is always going to be better than taking supplements, which, by the way, are not regulated in the United States. So it's hard to find supplements that are safe and effective.
Thank you. That's very good insight and suggestions for our participants. Maybe you could just answer the question in the Q&A with the website, if that's what you were referencing, and that way people would have access to it there in the Q&A. So I was also going to say, perhaps those of you with locations, such as, the Lincoln Community Health Center, which is represented by Awanya Caesar on the call today, maybe if you could just put a phone number for Lincoln Health in the chat or in the Q&A, so people would have that phone number readily available. And then Jackie with Survivor Friendly, same thing. If you could at least put your address, a website maybe, phone number for Survivor Friendly in the chat, that would be great. And I see Dr. Whalens, you already took me up on that and put your website in there. It's just that way it'll be easy access for our participants today to reference. But that was a great question. Thank you for that. So just kind of coming back, I saw a question earlier about lymphedema and how long do you have it? Maybe a little bit about how it's treated. Dr. Miller, do you think you could give us a little answer on that, please?
Sure. Hi, everyone. I'm Dr. Miller. So as far as lymphedema, unfortunately, yes, it can be a side effect that patients have to deal with. We have many, many resources at Duke to help with this. We really try to make life manageable for you. There's different things that can be used, such as, certain types of massage and certain compression, like you wear a compression sock on your leg, you can wear one on your arm. And, usually or sometimes it will improve, and that's what we're hoping for. But again, we do have resources to help with this if people are suffering from it. And we do assess it every time that you come in and see us after surgery or after certain radiation treatments or whatnot. It is assessed, and we definitely talk about it and address it.
Excellent. Thank you so much. I'm not seeing any other questions come in. I see a shout out to Sherry Wright and Awanya that work so hard with our community and trying to make sure that everybody has access to the resources that they need to take care of themselves. Awanya, I see you turning on your video. Do you want to share a few words with us about Lincoln Health? I think you're muted still. There you go.
Can you hear me?
I can hear you.
Okay, thank you all so much. It's been great. I've learned a lot, and especially what's available out here that will also assist our patients. I'm talking to you about Lincoln Community Health Center. Lincoln Community Health Center, we've been around since 1971. We provide primary and preventive health care for all patients, but most of our patient population is really uninsured and underinsured. However, due to the breast cancer control program, the BCEP program, we're able to provide breast cancer screening, that's mammograms and cervical screening, to our population. So I have been employed at Lincoln as a registered nurse for 33 years now, and I am committed to our mission and to making sure that our breast and cervical cancer patients that are diagnosed with cancer receive the care that they need. And I have found that collaborating with Duke Services, and we have a monthly women's health meeting task force have helped me to close the gaps and get my patients the care that they need. So I want to say thank you all so much. We are definitely the city of Madison, and we are committed to making sure that the Durham community and surrounding areas remain healthy. So hopefully we continue on that mission. Thank you.
Thank you so much. And we're really glad you were able to join us today. I don't see any other questions coming into the Q&A. There have been some resources listed over in the chat function, so check out those. There's some websites listed, some addresses, phone numbers. Thank you for all of the panelists on the spinal education panel today. I will leave the webinar open for a few more minutes for those that want to access the information in the chat, the addresses, the websites. But otherwise, this will conclude today's event. Thank you again to all of the attendees, the panelists, the speakers, the moderators. Another fantastic day. And we look forward to having our 6th annual What's Best for Breast, hopefully in person at Duke next year. We hope you'll consider joining us. Thank you everyone for attending today. Have a great day.
Have a great day.
Thank you, everyone.
It appears there are still a few people on the webinar, but I'm going to be closing it down in 1 minute. So if there are any additional links you want to click on or things you need to write down, please do so in the next minute, and then I'll be closing the webinar. Thank you again for your attendance.